Morning, dear students. We'll start the session today, starting with the part. The very first question is like about the principle of a surgery, which says that the attractive force is converted into compressive force. Now, we have to identify what actual surgical procedure is and for which of the following fractures is done. So, firstly, let's discuss this principle as such. So, suppose if there is a fracture, there are certain destructive forces. Now, destructive forces are the one which actually takes the fragments. Suppose this is one way the fragment will go, and this is another way the fragment will go. This is of course the fracture. So, usually the destructive forces are pulled by the muscle. So, destructive forces are the one which takes the fragment, and this is something which is not good for fracture healing. Now, we do some surgery in which whenever there is an attempt to extract the fragments, it actually brings the fragments closure, and this aids in union of the. So, this principle is actually applied for surgical procedure known as tension band wiring, known as W, and the fractures where we do this is of course the one is for fractures of patella, and the second one is fracture of olecranon. Now, the assembly of this tension band wiring, we use 2K wires. This is one, second, and then these are passed along the bone. Suppose if there is fracture there like this, the 2K wires are passed, and then we use a stainless steel wire, and this is placed into a figure of 8. Right? So, it is something like figure of. So, if you do this kind of surgery, the moment there is any force which tries to take the fragments apart, it rather brings the fragment closure. So, this is the principle of the surgery. Active forces are converted into, and this aids in. So, this principle is actually for tension band wiring, and we mainly do it for and for fracture of olecranon. You can also do it for medial malleus. So, just remember two fractures at least. Number one, number two, olecranon. So, these are the two fractures for which you should remember tension band wiring. Then coming to the next question, patient presented to the OPD with pain and complaint in the left shoulder following fall on outstretched hand. There was a fracture of clavicle, which is X-ray, and then was asked like what commonest site of fracture. Before we go on to discuss the fracture proper, there is one term, and that is known as foosh. So, this foosh injury is nothing except fall on outstretched. So, fall on outstretched hand, this is in short we write it as foosh injury, and this is one principal way in which we have fractures of the upper limb. So, it can involve any bone, it can involve fracture, right, or supracondylar fracture, this any injury, Colles even. So, this foosh injury is very common for injuries of. So, most of the time whenever you will have a of fractures involving upper limb, definitely you are going to case history. So, Fuchs injury. Now, coming to the improper, if you look at the image, here you can see that the clavicle is fractured, of course. One fragment of the clavicle, this is another fragment. So, if you look here, this is medial third, and this is, so obviously the most common site of fracture clavicle comes out to be the junction of medial 2/3 and lateral. Sometimes in MCQs they won't give you this option, then what? In such cases you should go for lateral, right? So, priority wise, the most common site of fracture is junction of medial third with lateral 1/3, right? So, it can be the first, and if it is not there in the options, you can choose fracture lateral. Either of the two you can take as per the given. Now, apart from this, what else you need to know? One thing is why this site is particularly common, why this particular site is common, like the junction of medial 2/3 with lateral 1/3. So, for that you need to understand the cross sectional anatomy of clavicle, because if you ever have seen a clavicle, it is rounded in middle 2/3 and flat in lateral 1/3. So, that junction point, the point of transition from that circular bone to a flat bone, that is the one of the weaker areas, and therefore the bone tends to fracture from that particular site, right? Now, apart from that, you can see the displacements are quite obvious. If you see the distal fragment goes, the lateral fragment, pardon, the lateral fragment goes downward, and the proximal, the medial fragment, it goes upward. So, if we talk about the displacement of fragments, so if you see here, the medial fragment going upward, it is going upward, and that is because of the pull by the sternocleidomastoid muscle. So, this is because of the pull by sternocleidomastoid, and if you look at the lateral fragment, the lateral fragment is going downward, right? So, it is going downward, and this is because of gravity, the effect of gravity, gravity. So, these are the typical displacements which you will see in a case of fracture of clavicle. Now, I think management wise, all of you must be knowing that it is quite one of the easy fractures to manage. So, what we need to do, simply we need to give a figure of 8. Just give a figure of 8 and just make sure that the figure of 8 is on the back side, not on the front. And this is one fracture which unites readily, and even if there is any sort of malunion, it does not hamper with the functions as such. So, malunion, even if it is there, it is of no concern to us. So, functionally it is not a problem at all. So, I think fracture clavicle is quite important. One should be very clear with the basic concepts, at least the ones which I have discussed with you. Now, moving ahead, taking another question, patient with recurrent dislocation. So, there is possibility of the dislocation of the shoulder again and again, and when the doctor tries to abduct and externally rotate, patient does not allow the doctor to do so. So, if you look at the movements, abduction and external rotation. So, these two movements at the shoulder, these two movements are the one which actually promotes dislocation, especially the anterior dislocation. So, the moment the doctor tries to do abduction, external rotation, the patient is very apprehensive that now my joint is going to dislocate. So, we will stop the doctor, please do not do this, or he will just resist the procedure fearing that my joint will dislocate. So, there is apprehension, there is fear, and therefore, we call this test as the apprehension test. So, the moment the orthopedician tries to abduct and accelerate the upper limb, the patient will resist movements fearing the possibility of shoulder anterior. This is apprehension test and very commonly seen in recurrent dislocation. Now, apart from this, you should know few facts about shoulder dislocation. Now, shoulder is the most common joint in the body to dislocate. One of the important fact is that it is the most common joint in the body, and once it is dislocated, and if you do not reduce properly, or if you do not manage it properly or adequately, it has a tendency to undergo recurrent dislocation. Most common joint to undergo recurrent, right? So, it is the one which commonly undergoes dislocation, and it has a tendency to undergo recurrent dislocation, right? Now, the most common variety, the most common type which we see in clinical practice is anterior, and here the head of humerus lies below the coracoid process. So, it is known as sub. Right? So, anterior subcoracoid is the commonest variety. Then we see we have certain tests to check for shoulder dislocation. One is Dugas test, and in Dugas test the patient is not able to touch the tip of opposite shoulder, right? Because there is no movement at the shoulder joint, so it is not possible for the patient to touch the tip of opposite normal shoulder. So, that is Dugas test. In Hamilton test, we place a ruler on the lateral aspect of the arm, and if the shoulder is in normal position, it is not possible to touch both the tips of lateral epicondyle and the acromion process simultaneously in a straight line. So, that is Hamilton ruler test. In Callaway's test, because of the shoulder dislocation, the circumference or the vertical circumference of the axilla, it increases because the head of humerus is also lying there, right. So, these are three which are done for shoulder dislocation. Right? And then coming to the treatment, any dislocation anywhere is a surgical, it's a clinical emergency. So, we need to do emergency reduction, right. And the procedure which we do commonly in clinical practice is the Walker's maneuver, in which the sequence of step can be remembered by the mnemonic team. So, traction, external rotation, adduction, medial rotation. So, this is in short about shoulder dislocation. And if someone asks you about the most commonly injured nerve, then your answer has to be axillary. I think this much is enough for shoulder dislocation. In the test in which the orthopedician is trying to abduct, accelerate the upper limb, the patient will not allow to do that. It's the apprehension test. Okay. So, this much is all about anterior shoulder. Now, we will move further on to next question, and the case history starts with a young male who is epileptic, and following a seizure he had developed pain in the right shoulder, and when the examination was done, it was seen that the right shoulder was adducted and internally rotated. So, adducted and internally rotated. Now, why I kept this question over here? Because we just discussed anterior shoulder dislocation, and in which we discussed abduction and external rotation. Now, look here, the words are adduction and internal rotation. So, the terms are exactly opposite to what we have discussed in anterior shoulder dislocation. And secondly, in a clinical setting of epilepsy or electrocution with adduction internal rotation, it always goes in favor of the diagnosis of posterior dislocation of. So, for posterior dislocation of shoulder, you need to just remember 2-3 things. Posterior dislocation. Now, this is very rare variety, right? This is a very rare variety. And just write. Very rarely we see cases of shoulder dislocation. It is commonly seen in epileptics during a seizure attack, epileptics, or if there is an electrocution, electric shock. So, these are the predisposing factors. Whenever you have a case history which starts with patient with known case of epilepsy having a fit, or if there is an history of electrocution, think of the possibility of posterior shock. Now, on X-ray, we see an important sign that is known as the electric bulb sign, just because of the typical displacement of the humerus. So, this much is enough for posterior shoulder. And since we have discussed anterior, so I thought of keeping this particular question, so at least we can discuss a couple of words for posterior shoulder as well. Then moving forward, the case history starts with post-menopausal woman, right? And there is a fall in bathroom, and there is this Fuchs injury. So, this is Fuchs injury, and she developed a bony fracture. Now, whenever you have a case history of a post-menopausal lady or an elderly male, you always think of the possibility of pathological fracture, which is usually osteoporotic fractures in an elderly, right? So, this particularly is a case of osteoporosis, because we know that in an elderly lady there is deficiency of estrogen, which promotes osteoporotic phenomena, and that makes the bone quite weaker and very vulnerable to fractures. So, in osteoporosis, we are mainly interested in discussing few conditions. One is fractures of vertebrae, right? They can be seen. Then fracture neck of femur, and third is fracture Achilles. So, these are the three commonly seen fractures in an elderly patient. It can be a male, it can be a female, but yes, of course, in a post-menopausal lady, the effect of osteoporosis more seen, right? So, considering the upper limb fracture, we can go for Achilles fracture in this particular. So, we can see pathological fractures in vertebral bodies, we can see pathological fracture in neck of femur, and the underlying process is osteoporosis. So, just few words for Achilles fracture. We take, it is at the lower end of radius at corticocancellous junction. Now, how you will identify given X-ray as a case of fracture Colles? Before that, just of this before. Now, what you need to do, you have to look at the fragment. So, suppose this is the proximal fragment, and then you need to look at the displacement of the distal. This is proximal and this is distal, and we look whether the distal fragment has gone volarly towards the palm or dorsally towards the back. We have to just look at that first. So, in a case of Colles fracture, it goes dorsally, it goes backward, right? So, the moment you find the dorsal displacement of the distal fragment, you can say that this is a case of Colles fracture, right? And this dorsal displacement actually gives the dinner fork deformity. So, this is one thing. Now, what if the fragment goes volarly? It goes on the anterior aspect. What we will see then? If it goes volarly, suppose if it is lying somewhere here, suppose if it is lying somewhere here, you say this, then is volar, then this is known as Smith's fracture, right? So, here it will be known as Smith's fracture, and as you can see that the displacement of the fracture or the distal fragment is opposite to Colles. Therefore, this is known as reverse, right? So, that's the reason why we call Smith fracture as the reverse Colles, because we look at the displacement of the distal fragment. If it is coming towards the volar side, it is known as Smith. If it is going backward towards the dorsal side, it is the Colles fracture, right? So, this is how a lower end radius fracture, whether it is Colles, whether it is Smith, we have to make a decision based on the displacement of distal fragment. Clear? So, that is very important. And since the displacement of the distal fragment in a Smith fracture is opposite to that what we see in Colles fracture, Smith fracture is also known as reverse Colles. Then in Colles, we saw that there is dinner fork deformity. In cases of Smith, we will see garden. So, please remember this much, Colles and Smith. It will cover the important points related to exam. Anyway, then moving on to next question. A patient had pain in the right hip joint few months, and when the examination was done, it was noted that there is true shortening of, then the lower limb was in an attitude of flexion, adduction and internal rotation, and specifically there was no history of trauma. So, if we can just write down these words, number one, there is true shortening, and number two, there is flexion, adduction and internal deformity. And third, you can also write no history of. So, we have 3 points in this answer. We will take the points one by one. Now, what do you mean by the word true shortening? Whenever we want to measure the length of a lower limb, we always measure from anterior superior iliac spine to the medial malleolus, and we compare it with the other side. So, when we are saying that there is true shortening, means the actual length of the limb, number one. Number two, if you look at the deformity, flexion, adduction, internal rotation. So, if I just write a short word for this, this is fader. This is fader. Now, many of you must have heard that fader after injury is posterior hip. So, the moment if there is any injury to the hip, patient having fader deformity, the answer has to be of hip. But since in this question specifically it has been written that there is no history of trauma, so we have to exclude this, cannot be the answer. Now, okay, let's go back to the options, and they are mentioning certain stages of the tuberculosis of hip. So, certainly this is a case of TB of hip, and now we have to discuss the different stages so as to reach up to the answer. For ease of understanding, I will divide the tuberculosis of hip into 3 stages. So, one is the stage of synovitis. This is the stage of synovitis. Second is early arthritis, and third is late arthritis. These are the 3 stages. Now, what happens in the first stage? The pathology, I write the word pathology here, there is inflammation of synovium, right? In this stage, there is inflammation of synovium. Now, what will happen? The function of synovium is to produce synovial fluid. So, whenever there is an insult to synovium, what it will be do? It will be producing more of synovial fluid. So, it will react by producing more of synovial. Now, the joint space is limited by a capsule and it cannot stretch much. So, just to accommodate this excessively produced synovial fluid, joint will assume position in which it can accommodate excess of synovial, right. So, the hip joint will assume a position in which it can accommodate this excessively produced synovial fluid, and for hip joint that position is flexion, abduction, external rotation. So, that position is, in short, you can write Faber: flexion, abduction, external rotation. Okay. So, this is the position of the hip joint which can accommodate large amount of synovial. Now, what will happen the moment the patient assume this posture for the lower limb? From a distance, it appears as if the limb is lengthened, right. So, it seems as if the limb is longer than the opposite normal. So, this is known as apparent lengthening, because if you measure the limb length of both the sides, it is equal. It is only just that from a distance it looks longer. So, we will use the word apparent. If you measure the length, it will be absolutely equal to the other normal side, right. So, this is stage of synovitis where you will find Faber deformity, and apparent lengthening. Now, if the condition is not treated at this stage, what will happen? The patient will move ahead to the stage of early arthritis. It means there is early involvement of the joint fracture. And what happens here? There is irritation of the surrounding muscles. So, because of the inflammation of the joint, there is irritation of the surrounding muscles, and the muscles, they try to move the hip joint in the direction of their action. Now, we know that there are flexors and extensors of hip joint, there are adductors and abductors of hip joint, and there are external rotators and internal rotators of the. Now, the muscles which are more powerful than the opposite antagonist muscle, they will pull the hip joint in the direction of their action. And in relation to the hip joint, the powerful muscles are the flexors as compared to extensors, right? Adductors as compared to abductors, and internal rotators as compared to external rotators, right? So, flexors are more powerful than adductors, are more powerful than abductors, and internal rotators are more powerful than. So, now what will happen? These muscles, they will pull the limb into an attitude of flexion, because flexors are more stronger, adduction because adductors are more stronger, and internal rotation because the internal rotators are more stronger, right? So, the muscle groups which are more stronger will pull the lower limb into direction of their action. So, what kind of deformity we are getting here? Now, this is Fadir. Clear? So, here we are getting a Fadir deformity. Now, since the limb has been assuming this kind of posture, flexion, adduction, internal rotation, so from a distance it appears as if it is shorter than the others normals. So, this is known as apparent shortening. Right? Again, if you measure the length of the affected side, it will be equal to the normal side. So, it means length of both the sides are same. It is just that it appears short. We have used this word apparent, right? And the limb length will not alter because there is no bony damage as. Now, if the person moves onward to further stages, the stage of late arthritis, where there is actual bone damage. Now, here there is actual bone damage to the head of femur. So, what will happen? Everything will remain same. We will have the Fadir deformity here, the same, but since there is actual bone damage, so when you will do measurement, you will find true shortening. So, only in the late arthritis stage, because of actual bony damage, you will find true shortening. So, this is very important. So, the moment you find a case with true shortening, Fadir deformity, the answer has to be the stage of erosion of TB hip or the late stage or advanced arthritis stage. Okay. So, this is how you have to remember the stages of TB hip. their clinical manifestations in terms of the attitude of the lower limb and the limb length. Limb length will always be affected only if there is actual bony damage. So therefore, we find true shortening in the late arthritis. So please remember this much, and just let me summarize 2 points. In first stage, Faber apparent lengthening. In second stage, Fader apparent shortening, and in third stage, Fader with true short. Please remember this much, and this will summarize the entire. Right. Let's move on to another question. A 5-year-old child with knee pain, irritability, and gum bleeding. Right? So the moment you find the word gum bleeding, I think most of you can get up to the answer. So, and when we took an X-ray, we find significantly thin cortex and a white line at the metaphyseal. Right? So this all presentation very specific for curvy. Now, everyone knows that in scurvy there is defective collagen formation, and that manifests as gum bleeding. In terms of X-ray findings, what we can see, and even in this MCQ it has been mentioned, a white line, and this is white line of ankle. So if you look here, this is the white line of ankle. Then we can see pencil in cortex. See, the cortex are thinned out. Then you can see a falcon spur, and you can see this black shadow here, that is actually Trummer-Feld. So very classical X-ray of scurvy. You can also see subperiosteal hemorrhages or Wimberger ring sign. So this is all for scurvy. So please remember the radiological features of scurvy. Then an obese woman came to OPD with pain in both the knee joints and can hear sounds click while walking. Pain tends to be more severe while she is going downstairs, and X-ray is shown. So now here, if you look at the keywords, one is obese, then some problem with the knee joint, and which is more particularly when she is going downstairs. So if you look at the X-ray, just look at the joint space here and just look at the joint space here. Now this is known as reduction in joint space. So the articular ends of the femur and tibia, they have come quite closer, and that happens because the intervening cartilage has degenerated. Okay, so the cartilage which is actually present over the bones, right? This is, we know that this is hyaline kind of cartilage. So as it degenerates, as it dies away, it brings the bony ends closure. And since these bony ends, they have nerve supply, so the moment when there is movement at the joint, whatever, like knee in this case, so whenever there is movement or whenever there is rubbing of those bony ends, it produces severe pain. So that is very classical for osteoarthritis. Now this word osteoarthritis, because I think all of you must be knowing that itis means inflammation. But this term is a misnomer here, because as such there is no inflammation, it is just a normal wear and tear the cartilage with age. So, this is osteoarthritis, and for osteoarthritis just remember few things. It can be primary when there is no underlying cause, and this is the one which is very commonly seen in clinical practice. It can be secondary when a articular fracture has not been managed properly. So, mismanaged intra-articular fractures, this is the common cause. And therefore, we always say that for intra-articular fractures we should go for ORIF, open reduction internal fixation, where the principle is to maintain the articular congruity. So, that is very important. That is why we always stress for the need of accurate reduction in maintenance of the articular congruity, right. So, these are the two varieties, and then if we talk about the joints which are commonly involved, it differs. Like in Western world, the hip joint is commonly involved, whereas in Indian setup there is common involvement of knee joint. We see more cases of knee joint osteoarthritis. Then coming to X-ray features, one we have already seen that there is reduction in joint space, and here we can also see that there is some opening up of the lateral aspect of the knee joint. So, that indicates that there is some varus deformity. This indicates that there is some varus deformities. So, if you ever see a case of knee osteoarthritis, you can very well appreciate the varus deformity at the knee joint. Now, coming to the treatment, once patient is having chest pain, means he is having pain 24 hours. So, in that case we need to go for total joint replacement, total knee replacement in this case. So, chest pain means 24 hours pain. So, we need to go for replacement. So, that is the usual management, and once the patient says that I am having pain throughout the day, throughout the night, then this procedure might. So, this is in short about osteoarthritis. Now, moving on to next question, again a very favorite question. A non-vegetarian person with redness and pain at the right grade. So, the moment you find the word grade 2, right? So, if there is any pain and swelling involving the grade 2 or the metatarsophalangeal joint or foot, then always and always you think of the possibility of gout, right? And if we go further, in this case we can say that the uric acid is 10. Now, the normal acceptable upper limit for uric acid is 0.5 to 7, somewhere around that. So, 10 is of course a little higher, and then there is past history of similar episode. So, this is a case of chronic gout. So, the point which favors the diagnosis of gout here, one is non-vegetarian, especially the people who consume red meat. Then the second point is pain, swelling, MTP joint, that is grade 2. Then raised uric acid. So, these are all in favor of the diagnosis of any value more than 7 can be taken as raised serum uric acid. Now, here the patient already had taken analgesic, and now doctor has given one more drug by which he is trying to reduce down the formation of uric acid. And since this is a case of chronic gout, because there are previous episodes as well. So, for chronic gout we can give allopurinol. Now, this is very important to remember that allopurinol is not given in acute cases, right. Please be very careful in this. In acute gout we do not give allopurinol, we give allopurinol only in chronic cases. So, for acute we can give painkillers, we can give steroids, we can also give. It is only in chronic gout we will give allopurinol, which actually inhibits the enzyme xanthine oxidase and therefore reduces the formation of uric acid, reduces uric acid formation by inhibiting in. So, this much for gout is okay. And yes, if you look for the crystals, you will find needle shaped negatively birefringent crystals. So, needle negatively birefringent crystals, which are made up of monosodium. So, I think this much is enough for gout. And again, gout is a very important topic, again and again you are in one or another. Now, moving on to another question. Alcoholic patient slept with keeping his head over the arm, and when he woke up next morning there was radial nerve paralysis. Now, this is what kind of nerve injury? Now, here what we can presume from the case history, that there is no anatomical injury as such, it is just that there is some physiological disruption of the activity, and that is known as neuro. So, if you look at this is actually the Seddon's classification. So, this is the nerve as such, and this is the. So, in neuropraxia, nerve anatomy is okay. Anatomy is okay. It is just that the physiology is disturbed. Means there is no conduction across the nerve. The physiology is disturbed, and since the anatomy is okay, we can expect complete recovery. Complete recovery is expected. So, neuropraxia is one of the kind of nerve injuries which carries good prognosis, because we can expect 100% recovery, as the anatomically the nerve is quite okay. It is just that there is transient or temporary disorder of conduction across the nerve. Now, the another one is in which you can see that the axon is cut. When the axon is cut, it is known as axonot, and if the entire nerve is cut, this is known as neurot, right. So, the entire nerve is cut, this is neurotmesis, and obviously this will carry very poor. Clear? So, this is a Seddon's classification of nerve injuries. So if there is any compression over the nerve leading to disruption of the function of the nerve, that is usually a case of neuropraxia. If only the axon is cut, that is axonotomesis. If the entire nerve is cut, as may be seen during a operative procedure when there is the abnormal location of the nerve and accidentally it is cut, then it is a case of neurotomesis. Let's move on to another question. A young lady has tingling sensation in the thumb, index finger and middle finger, and this abnormal sensations can be aggravated if the wrist is palmar. So, if the wrist is palmar flexed for 1 minute, the symptoms aggravate. Now, if we look at the area of this paresthesia, this is right thumb, index finger, middle finger, and we can just add half of ring finger. This all is territory of cutaneous distribution of median. So, whenever a patient comes to us with tingling, numbness, burning sensation in this much area, lateral 3.5, volar aspect, it suggests that there is some compression of median nerve. And if we palmar flex the wrist for 1 minute, it will further aggravate the compression over the median nerve and the symptoms will be more pronounced. So, this particular test is known as Fallon test, right. So, this is Fallon test, and this actually is done to aggravate the compression of median nerve in the carpal tunnel. So, this case is actually carpal tunnel. So, carpal tunnel syndrome, you can look in this image, there is compression of the median nerve as it passes through the carpal tunnel. Now, anatomy of carpal tunnel, the fibro-osseous tunnel. On the lower side, we have the carpal bones. On the lower side, we have carpal bones, and on the top, there is a flexor retinoculum. So, there is a flexor retinoculum here, and therefore, this area, whole area is converted into a tunnel. So, this is a tunnel as such, and through this tunnel there is passage of the median nerve along with the long flexor tendons. Now, sometimes, now this tunnel is a closed space. In certain conditions like pregnancy, or you say hypothyroidism or amyloidosis, there is possibility that there is some aggravation of the compression of the median nerve within the carpal tunnel, and then it leads to the carpal tunnel syndrome. So, this is the classical area of paresthesia if the patient is having carpal tunnel syndrome or the compression of median nerve in the carpal. So, you can see the thumb area, index finger, middle finger, and half of the lateral aspect of the ring finger. So, please remember this lateral 3.5 rule, polar aspect. So, this is the typical distribution of nerve, and whenever there is compression of the median nerve, patient will have altered sense, burning, sense, pricking, numbness in this particular area. That goes in favor of the diagnosis of carpal tunnel syndrome. In the moment you palmar flex the wrist, preventing the compression over the median nerve, the symptoms will be more pronounced. Now, what we need to do for carpal tunnel syndrome? For carpal tunnel syndrome, we can give a splint, it is splint, so as to prevent flexion at the wrist. If this doesn't work, then we can go for local steroid injection because of its anti-inflammatory properties. And if this doesn't work, then we need to do a decompression surgery. Decompression surgery means we have to cut the reticulum, and that will make space for the nerve to breathe. Right. So this is in short about carpal tunnel syndrome. Symptomatology is quite classic. One can easily identify that. Right. So carpal tunnel syndrome is for median nerve. And please don't confuse carpal tunnel syndrome with cubital tunnel syndrome, because cubital tunnel syndrome is for ulnar nerve. So you can remember U for ulnar nerve, right? So carpal tunnel syndrome, median nerve; cubital tunnel syndrome, depression neuropathy, ulnar nerve. Now, patient was operated on elbow, but later on he was unable to flex the index. Flexion of the index finger was lost. And whenever you find any nerve injury resulting in any affection of the index finger, just think of one term, pointing index. And the moment you recall that term, pointing index, it is very easy for you to identify the nerve or to understand of what nerve we are discussing. So here the patient is not unable to flex the index finger. It means the flexors of the index fingers are paralyzed, and the flexors are flexor digitorum profundus and flexor digitorum superficialis, which are supplied by median nerve. So it means there is median nerve injury. That is how you can reach up to the conclusion that this is a case of injury to median. Now here, now this all fact can be summarized in terms of certain tests or certain postures. So one is, of course, as I told you, pointing index, right? And second is Ochsner clasp. The moment you tell the patient to make a clasp, the index finger will remain extended like this. This is because the flexor digitorum profundus and digitorum superficialis are parallel. So this is one thing. Then somewhat similar is sign of benediction. So these are certain terms which can be discussed based on this concept of analysis of FDS and FDP. Now one should remember one thing here, that FDP is a hybrid muscle. It is a hybrid muscle and it has got a dual nerve supply. It has two halves, lateral half and medial half. The lateral half is supplied by median nerve, the AIN, median trochleus nerve, and the medial half is supplied by the ulnar. So therefore, whenever we talk about the paralysis of FDP, it is going to affect these two fingers only, because medial half is supplied by ulnar nerve and that is spared. So these two fingers will not be in terms of FDP. FDS, all whole fingers are gone. So this is the basic presentation if there is injury to median nerve related to long flexus paralysis. Also we can have other terms also, like wasting of thenar eminence or ape thumb deformity. So this is particularly in relation to FDP and FDS, flexor digitorum profundus and flexor digitorum superficialis. So please remember. Now, another important segment, and that is bony tumors. And always and always we have. Now, the question is eccentric epiphyseal tumor which can extend up to metaphysis. So, the moment you find double E, eccentric epiphyseal, the moment you find double E, think of giant cell. Now, what does this word eccentric mean? Eccentric means, suppose if this is a bone, suppose this is a bone, and if the tumor is more onto one side, this is known as eccentric. Right? So, if the tumor is more towards one side, it is known as eccentric. And I think epiphyseal is clear to all of you. It arises in the epiphysis, and this particular tumor then extends towards. So, this is giant cell tumor, and if you look here, this is a classical picture of giant cell tumor involving the lower end of radius. You can see that the tumor is more towards one side. So, you can say this is eccentric. It is arising from epiphysis, so it is epiphyseal. Now, what extra do you need to know here? I think most of you must be knowing about the soap bubble appearance. And that is because the tumor is a lytic lesions and it has tuberculation something like this. So, this gives rise to the typical soap bubble. So, this is one thing. Now, there are some other points which you remember. Number one is about the histology. This is very important because we have most of the time. Now, here whenever we will do histopathology of giant cell tumor, we will see two kind of cells. One is mononuclear cells, are spindle shaped cells, and the another one are the multinucleated giant cells. Previously, by looking at these giant cells, and these were mistaken as the tumor cells. So, these were mistaken as tumor, and hence the condition was named as giant cell. So, the giant cells, if I draw a giant cell, so giant cell will like this, a big cell, and it will have multiple nuclei. This is giant cell. This is a giant cell. And if I draw a mononuclear cell, so previously these giant cells were considered to be as the tumorous cells, and therefore the nomenclature was the giant cell tumor. But these are not the tumor cells, these are actually the tumor. So, that nomenclature of giant cell tumor is an erroneous nomenclature, because these giant cells are not the tumor cells, the mononuclear spindle shaped cells, actual tumors. And it was also presumed that these giant cells might be having some osteoclastic activity, and therefore it was also named as osteo. The giant cell tumor, osteoclastic, same thing, and this is important in relation to, please remember. Now, coming to treatment, especially in cases of lower end of radius, we need to excise this part, and we have to take a fibular graft from the opposite side, and it has to be fixed in an inverted position so that the head of fibula is somewhere here. So anyway, so please remember this much for giant cell tumor, a very important entity from exam point of. Then next question, elderly patient with hypercalcemia and features of renal insufficiency, RBC count is low and X-ray is shown, most likely diagnosis. Now what we can see here, that there is raised calcium levels, then there is renal failure, renal insufficiency features, RBC is low because of the renal involvement, and particularly in the X-ray we can see multiple punched out lesions. You see these black densities, these are known as multiple lytic punched out. The moment you have this kind of presentation, especially over the skull X-ray, you can very well say that it is a case of multiple myeloma, which is a plasma cell dyscrasia. So multiple myeloma, and for multiple myeloma, remember one more important thing, why it is being discussed in orthopedics, because it is the most common primary malignant bony, right. So if I say most common primary malignant bony tumor, the answer has to be multiple myeloma. If I remove the word primary from here and if I simply write most common malignant bony tumor, the answer will be metastasis, right. So this is in relation to malignant tumors. If I use the word most common primary benign bony tumor, the answer will be osteoid tumor. And if I remove the word primary from here, I write most common benign bony tumor, the answer will be osteo. Clear? So simple change of few terms changes the entire meaning of the question in consideration. So please remember this much. Anyway, so this is for multiple myeloma. Whenever you see a case of, whenever you see a skull X-ray with punched out lytic lesions in a typical setting of raised serum calcium, renal insufficiency, the diagnosis. Then next question, a patient came with lower back pain, and when you did X-ray of spine, you saw sclerotic lesion. Now, sclerotic lesions, you can also call them plastic lesion, means there is formation of new bone, and new bone will appear very white. This is all the whiteness which you see, this is all new bone formation, right. So this is known as osteoblastic metastasis, because usually what we see in cases of metastasis, that is usually osteolytic. Whenever we see metastasis from tumors like carcinoma, endometrium, and breast carcinoma, the tumors, when the tumor cells reaches the bone, they will destroy the bone, and therefore the term is osteolytic metastasis. But especially in cases of carcinoma of prostate, cancer cells, they will promote new bone formation. So this is very unique concept. So there is new bone formation, and therefore we use the word osteoblastic or sclerotic metastasis. So this is very unique, please remember. Then next question, 15 years old boy with a mass in distal femur is given, what can be the diagnosis? Now, if you look at the age is 15 years and there is involvement of the distal femur. And if we look at the X-ray, we can see radiating lines, something. This is known as the sun ray appearance. This is sun ray appearance or the sunburst appearance. And I think most of you must be knowing where we see this sun ray appearance. So this is a very classical feature of osteosarcoma. Osteosarcoma, a very aggressive or very malignant tumor. And most common patient is around the knee joint, where lower end of femur is the first site to be affected. Lower end of femur first, and second is upper end of. On X-ray, you will find two things. Number one is, of course, the sun ray appearance, which is actually the calcification along the blood vessels, the Sharpie's fibers. And the second is the Codman's triangle. Codman's triangle, whenever there is lifting of ariosteum, there is a angle, something like this. So this is known as Codman's triangle. And since this is very aggressive tumor, so at times it presents with metastasis, maybe in lungs, and if you do X-ray, you will find cannonball shadow. Now, prognosis is extremely poor. We can do amputation and other surgeries, but despite that, death occurs. So this is in short about osteosarcoma. It happens to be very malignant. Now, a child presented with multiple fractures and his sclera were blue. So this condition is actually osteogenesis imperfecta. Now here, please remember one thing, that in this particular condition there is defect in collagen synthesis, and there is blue sclera, but this blue sclera can be seen in normal child also, normal infant also. This doesn't mean that if you see an infant or a child with blue sclera, you will label him as a case. Don't do that. Right? So here we can see multiple fractures, and then consequent deformities. So this is a typical case of osteogenesis imperfecta. We can try putting some biodegradable rods, which are known as BD rods, but osteogenesis imperfecta. Then next question. An army recruit, right, and 6 months into training, and there is pain at posteromedial aspect, and there is acute point tenderness, and the pain aggravated on physical. Now, what is the likely diagnosis? Now, firstly, look at the occupation. It's a case of army recruit undergoing vigorous training, pain in area, and which increases with activity, and there is acute point tenderness, means the pain is felt only at one point. If you press that point, pain will be very severe. Acute. Whenever you have these kind of words, it goes in favor of stress fracture. And what actually is stress fracture? Stress fracture is also known as march fracture. And march fracture means like people who used to do a lot of march past or parade, like army, these recruits, whenever they do a lot of march past or parade, they can cause, they are liable to have stress fractures. And the commonest site of stress fractures can be involving the second or third metatarsal or lower end tibia. These are the usual sites of stress fracture. So if you see any case history starting with army recruit or police recruit presenting with pain in the foot or in the shin of leg, think of the possibility of stress fracture. Stress fracture means that whenever we keep on giving repetitive stress to a particular region of the body, to a particular bone, it undergoes, that is known as stress fracture, or particularly in this case it is known. Then moving on to the next question. A patient was on long steroid therapy and now is complaining of pain in both the hip joint. This is a case of avascular necrosis of head of femur. Now most of you read avascular necrosis in terms of trauma. Avascular necrosis, that AVN, as the name suggests, A means vascular, means blood supply. What happens? There is interruption of the blood supply to a part of bone and then it undergoes necrosis. So that we have read in terms of trauma, and especially fractures like neck of femur or of talus, fracture through the waist of. So this is the usual AVN in traumatology which we usually discuss. But sometimes if patient is on long term steroid therapy, he is also liable to develop non-traumatic AVN of the head of femur. So this can be a possibility. Not that only in traumatic cases we can find AVN. It can be seen in non-traumatic conditions as well, especially steroid therapy or Kaizen's disease. Now what actually we see in X-ray? If you look here, this is normal and this is AVN. Now on the normal side you can see such a rounded contour of the femur, whereas if you look on the other side, it is irregular and depressed. Right? So one thing, you can see the contour of the head of number one. So if you have to look on the X-ray at the contour or the shape head of femur, and number two, you will look in the density of head of femur. Right? So normally it should be uniform density, but if you look here, you can see white is in the AVN, too much of white patches, and that actually suggests that areas have undergone avascular. Right? So very easy to identify on X-ray, but yes, the changes on X-ray are appreciated quite late. If we have to appreciate the changes little early, we can go for MRI. So this is AVN, avascular necrosis. Now, a 5-year-old child presented with genu varum deformity. Osteopenia was seen. Vitamin D is less, and alkaline phosphatase is high. Vitamin D is less and alkaline phosphatase is high. Now, whenever you see a case of child with genu varum deformity and osteopenia, low vitamin D, low calcium, raised alkaline phosphatase, this is a typical case of ricket. So, this is a typical case of, I think genu varum deformity is quite obvious to all of you. Which is also known as bowing of legs, is also known as bowing of in rickets. We can have any deformity, we can have genu varum or even wind swept deformity, but yes, genu varum is the usual complaint, because the pathology in rickets is that osteoid is good, but since there is deficiency of calcium, so mineralization is poor, and as a result of this the bones are quite. And if such a child starts wearing weight, under the effect of body weight, the lower limb bones they bend, giving rise to the typical bowing of legs, or is known as genu varum. Right? So, classical presentation of rickets. Then a young patient having tumor in right shin associated with pain and tend to relieve after taking aspirin. This is classical presentation for osteoid osteoma, and since it dramatically responds to aspirin, so it is also known as aspirin tumor. It is also known as aspirin. Now, what we see on X-ray, if we take X-ray or CT scan, we can see, now this is cortex. You can see this is cortex, and in the cortex we can see a nidus. Black shadow is a nidus, known as, right. So, what we write in description, that there is a cortical nidus, and the size is somewhere around 1, and this cortical nidus is well appreciated in a transverse section. So, if we take the transverse section, you can see a black cavity. This is cortical. So, the classical presentation, and you can see this is tibia. Of course, so tibia is the usual site, and you can see a nidus in the cortex, cortical nidus, and the patient have pain especially at night, relieved by taking aspirin. So, this is on the base of this particular feature, it is also in tumor. So, please remember osteoid osteoma, and as I told you before, this is the most common primary benign bone. Yeah, so osteoid osteoma. Then patient has RTA, and on examination the lower limb was in external rotation and appeared lengthened. So, external rotation, and we can also write one more word to make it more appropriate. We can write abduction, external rotation, and lengthening. This goes, and if you write it like in short form, it will be like Faber, right? And we can write it Faber because at times there is also flexion. So, this is kind of Faber deformity. Now, most of you must have studied Fadir for posterior dislocation of hip. Most of you must have studied Fadir for hip. Right? Now, Faber has to be remembered for anterior hip dislocation. Please remember this for anterior hip dislocation. And when we say anterior hip dislocation, it means the head of the femur is lying anterior to the acetabulum. The acetabulum behind, and the head of femur, it has moved anterior to the acetabulum. So, that is anterior hip. So, this is anterior hip dislocation, and if you look in the images, is given for reference purpose. This is after injury, and this is after reduction. So, post injury, you can see that now this is a case of bilateral hip anterior dislocation. You can see both the lower limbs are abducted. Means if you draw a line from the midline, both the lower limbs are going away. So, that is abduction. You can see some flexion at the hip joint and external rotation also. See external rotation, and external rotation, you can look at the lateral border of the foot. Just see the lateral border. Lateral border of the foot is touching the couch. So, this is external rotation. So, abduction, external rotation with flexion is anterior hip dislocation, and flexion, adduction, internal rotation, posterior hip dislocation. Please remember these two things, and it is quite easy to answer. Don't get mixed up in the words. Make sure that you are crisp and clear in the terminology, and the answer is quite easy. So, this is the second image is the B and D are after reduction. You can see the lower limbs almost in the anatomical position, and if you look at the X-rays, you can see the head of femur well within the acetabular socket. So, this is after reduction. So, anterior hip dislocation. Then a child have pigeon chest, rachitic rosary, bowing of legs, enlargement of wrist. Now, this is again a very classical presentation of kids. Again a classical presentation of kids. You can see pigeon chest, you can see rachitic rosary, which are actually enlargement of costochondral junction. Bowing of legs, I already told you, this is genu varum, and enlargement of wrist is because of enlargement of spices, that is the growth rate. So, we will see enlargement of wrist, and in fact, this is a very classical presentation. The moment you look at the patient, if you look at the wrist of the child, it will be very wide like this, and it gives an impression as if this is a case of the wide wrist. See here, classical for rickets. What you need to give? Obviously, you need to give vitamin. Right? Then next question, a patient presented to the emergency room after trauma, and the limb was in attitude of flexion, adduction, internal rotation. So, I have just kept this question once again. You can appreciate Federer deformity, and Federer deformity post trauma, one can say with confidence that this is a case of posterior hip. Clear? So, flexion, adduction, internal rotation. Federer is posterior hip. So, don't confuse. You can see in the image also, there is flexion at the hip, there is adduction, the knee is touching the opposite or even crossing the opposite knee, and there is internal rotation like this. So, this is posterior dislocation of clear. and we discussed about anterior dislocation. You can see abduction, you can see the flexion, and there is external rotation. So this is favor deformity for anterior dislocation, and this is Padir deformity for posterior dislocation. Please don't clear. Then if there is fracture of humerus, which all nerves can be injured. Now I think this has been discussed many times. Radial nerve can be injured if there is fracture shaft of humerus. Ulnar nerve can be injured if there is fracture of medial epicondyle, and median nerve, or especially anterior interosseous nerve branch, it can be injured if there is fracture condylar humerus. So please remember these nerve injuries in relation to injuries of humerus. Musculocutaneous nerve has not been described anywhere in relation to fractures of. So with this, we can end this session, take a little break, and we will be right back. Thank you. Hello dear students, welcome back. In this session, we will take MCQs of anatomy. And for better visualization, please increase the resolution of your video, make it 1080 higher. So we can start the anatomy portion. And the very first question is about a clinical scenario of portal hypertension, in which we know that there is portal system anastomosis. So in lower end of esophagus, there is dilatation of veins. So which vein is the one which is actually draining into the portal vein? So for that, you need to know the concept of portosystemic anastomosis. Porto, or what you call portocaval anastomosis. And here, in certain areas of the body, a vein from the systemic circulation and a vein of the portal circulation anastomose with each other. And from exam point of view, you have to remember at least three areas. Number one is the lower end of esophagus. Number two is lower end of anal canal. Number three is umbilicus. Right. So these are the three areas where the common one where we have this portocaval anastomosis. And now the clinical significance is that whenever there is cirrhosis of liver which leads to portal hypertension, there is opening up of these portocaval anastomosis. So in cases of portal hypertension, which is secondary to cirrhosis of liver, there is opening up of these portocaval anastomosis. There is opening up of the Now, why you should know this? Because what happens whenever these portocaval anastomosis opens up, there are significant clinical findings. So suppose if there is opening up of the portocaval anastomosis of lower end of esophagus, patient will develop varices resulting in hematomas. Similarly, if there is opening up of the portocaval anastomosis of the lower end of anal canal, patient will develop hemorrhoids. And in cases of opening up of the portocaval anastomosis around the umbilicus, that results in hepatitis. So this is a very beautifully correlated concept of portosystemic or anastomosis, and a student should remember at least these three. So there are veins which contribute to this portocaval anastomosis. One is from the systemic circulation and another is from the portal circulation. So in case of lower end of esophagus, the vein which is related to the portal system of venous drainage is the left gastric. So left gastric vein, as you can see, it goes and it drains into the portal vein. So this concept is very important from portal hypertension point of view about the portocaval anastomosis or portosystemic anastomosis. So one vein from the systemic circulation and another from the portal circulation, they anastomose each other, and whenever there is any pressure increase in the portal venous system, the condition is known as portal hypertension, and usually the value is more than 12 millimeter of mercury, then we call it portal hypertension, and this is seen in cases of cirrhosis of liver. So these anastomotic sites, they open up and they give varied clinical presentation. Right? So this is important from clinical point of view. Now again, very important question: if there is rupture of bulbar urethra, the urine can come out, and it can extravasate to some areas. Now for this you need to understand the anatomy of the urethra and the surrounding structures. So we know that in a male there are four areas of urethra, and the important one is, which is in relation to the prostate, is prostatic. Below that we have the membranous urethra, and then we have the bulbar, right, and then the penile part. Now the membranous urethra, if you look in the image, this red part is the deep perineal pouch, and the membranous urethra is actually passing through the deep perineal pouch. So if I draw like this, if this is the membranous urethra, then this is the deep perineal pouch. This is the deep perineal. And is membranous. Distal to that is the bulbar urethra. This is the bulbar. Now if there is any rupture to the urethra at this point, it can go either downward, it can go forward, or it can go upward, right? But it cannot go into the deep perineal pouch. So it will never go back into the deep perineal pouch. It can go into the superficial perineal pouch. So here this is superficial perineal pouch. It can go into the scrotum, or it can go into the anterior abdominal wall. So what you need to remember is that in cases of rupture of bulbar urethra, there is no leakage or extravasation of urine in the deep perineal pouch. So please remember this. So the urine can never go into the deep perineal pouch. Please remember this. Then moving forward to the next question, deep inguinal ring. Now for this you need to remember a little bit about the anatomy of the inguinal canal. So we have two rings. The inner one is the deep inguinal ring, and the outer one is the facial, and in between the two we have the inguinal. This is now deep inguinal ring is a defect in the fascia transversalis. It is a defect in fascia transversalis, whereas the superficial inguinal ring is a defect in the external oblique aponeurosis. Please remember, it is defect in the aponeurosis and not in the muscle belly proper. This is defect in the external oblique. Yeah. So this is deep inguinal ring and superficial inguinal ring. So this is fascia transversalis or deep inguinal ring. We have some more questions lined up based on the same concept we will take later. Now there is a case with nerve injury of upper limb, and when we saw the thumb, it was laterally rotated and adducted. There was wasting of thenar eminence. Now if you add up all these points, yes, very good, tape thumb, yes. So if you add up all these points, of course, this laterally rotated plus adducted thumb is what you call ape thumb deformity, and wasting of thenar eminence suggests that there is paralysis of median. So this is quite obvious. The answer is median nerve injury. So wasting of thenar eminence and ape thumb deformity is laterally rotated, and usually when we look at the thumb, if this is the plane of palm, the thumb is somewhat like this, but in cases of median nerve, it also comes to lie within the same plane as that of palm, and it is adducted because of overactivity of the adductor pollicis, which is supplied by ulnar nerve. Right. So this is a classical presentation for median nerve injury. Now, lateral boundary of Hasselbalch's triangle. Now, Hasselbalch triangle is very important in surgical discussions because it is the area for direct inguinal, and again we can take the little bit of anatomy of the inguinal canal. This is the deep inguinal ring, which is a defect in fascia transversalis, and this is the superficial inguinal ring, which is a defect in external oblique aponeurosis. Thank you, Raghu. Thank you. So what happens now? Just the basic difference between the direct and the indirect type of inguinal hernia. If the herniated content is moving from the deep inguinal ring and traveling all the way through the inguinal canal and coming out through the superficial inguinal ring, this is indirect inguinal hernia. Right? So entry through the deep inguinal ring, traveling all the way through the inguinal canal and coming out through the superficial inguinal ring. But think of a condition where the herniated content enters through the posterior wall, comes into the inguinal canal and comes out through the superficial inguinal ring. So it is getting a direct entry into the inguinal canal, so we call it direct inguinal hernia. Clear? Indirect through DIR, deep inguinal ring, and direct through posterior wall. So this picture is clear. What is direct, what is indirect? Now, for direct inguinal hernia, there is a landmark, and that landmark is the Hasselbalch's triangle. Therefore, it is very important for us to understand what actually is Hasselbalch's triangle. If we on either side we have the rectus abdominis muscle, right, the back muscle either side, abdominis muscle, and here we have inferior epigastric vessels. These are the inferior epigastric vessels, both the arteries and the vein. So this area, whatever is this, all area is the Hasselbalch's. That clear? So medially there is the abdominis, laterally inferior epigastric vessels, and below inguinal. So this is how the boundaries of Hasselbalch's triangles are defined, and therefore your answer will come out to be inferior epigastric. So this is the lateral boundary of Hasselbalch's triangle. And what is the importance of Hasselbalch triangle? It is the site of direct, please remember, inguinal. So therefore it is so. So this is Hasselbalch's triangle. Now, continuing the topic a little bit more, a male child presented with swelling in the inguinal area, and there was herniation of the intestinal loop along with rheumatic cord reaching up to the scrotum. Now, the two types of inguinal hernia which we usually discuss, one is the direct, another is direct. Okay. So, the direct, as I told you, it is through Hasselbalch's triangle, whereas indirect, it is through the deep inguinal. So, the entry point for direct is through the posterior wall of the inguinal canal, and for indirect it is through the deep inguinal ring. Now, clinically, direct is commonly seen in elderly people, and indirect is commonly seen in. So, the moment you read the case history, if the condition is discussing some elderly person or a young male, then probably it is talking about direct. And if the case history starts with children, probably it is about indirect. Third, direct inguinal hernia is seen in persons who are doing, some activities which increases intra-abdominal pressure, like laborers, weightlifters, or persons with chronic cough or some other condition which increases intra-abdominal. Whereas indirect, it is developmental, as we know that the condition is seen in children, so it is developmental, right? So this is the basic summary of how we differentiate direct inguinal hernia with indirect inguinal hernia. Yes, of course, somebody rightly said the answer is indirect inguinal hernia, and Litters hernia is actually hernia of Meckel's diverticulum. Meckel's diverticulum. And femoral hernia, I think for that you need to understand the anatomy of femoral triangle, and especially the medial part, that is the femoral ring, which is occupied by the lymph node of Pleuke or Rosenmuller, and this is the area which is usually vacant. So there are some chances that the bowel may herniate, right? So femoral hernia occurs through the medial most compartment of the femoral canal, right? So this is femoral hernia, and this is one of the most troublesome hernia because it is quite difficult to reduce, and the chances of strangulations are quite high. So it is kind of times it can be irreducible and it can lead to strangulation. Femoral hernia is quite problematic times because of that narrow point of entrance, narrow point of herniation of bowel, right, through the medialmost compartment in femoral triangle. So anyway, so this is inguinal hernia. Now then we come to some movements of the temporomandibular joint. So again, you know that in temporomandibular joint, it is only the movement of the lower jaw or the mandible which is possible. The upper jaw maxilla, it is fixed. So we always discuss the movements of the temporomandibular joint in terms of movements of mandible. We always talk in terms of mandible. So whatever the position of the mandible is, we will say that movement is occurring at the temporomandibular joint. Now the word is retraction. Now what does the word retraction means? Suppose if I am taking the mandible forward, this is known as protraction, right? And if I am taking it back to the usual position, that is known. So protraction means forward protrusion, retraction means back to the position. Protraction, and the opposite is retraction. Protraction means mandible pushed forward, and retraction means mandible taken backward to the normal position. Now this retraction is done by posterior fibers of temporalis. So the retraction is done by posterior fibers of temporalis. Protraction is done by lateral pterygoids, both medial and lateral. So protraction, which is also known as protrusion, means taking the mandible forward. So that is done by both the pterygoids, that is medial and lateral. And retraction is done by posterior fiber. So forward movement, backward movement. Forward by both the pterygoids and backward by the temporalis. Now, if we open the mouth, means the mandible is going downward. So that is known as depression. Depression means opening the mouth. Whatever movements we have to discuss, we have to discuss in terms of mandible only. So this is mainly helped by gravity. So this is mainly helped by gravity, easy to take it downward, and it is supported by lateral pterygoid. Clear? So depression or opening the mouth, that is by gravity and lateral pterygoid. And if we close the mouth, it means we have to elevate the mandible. Elevation or closing the mouth so here we have medial pterygoid, masseter, and closing the mouth or elevating medial pterygoid, masseter, temporalis. And then there is one more movement, and that is chewing movement. Chewing movements means side to side, like this. Chewing means side to side movement, and this is by alternate contraction of lateral pterygoid, medial pterygoid. So alternate lateral and medial pterygoids. Clear? So these are the different movements at the temporomandibular joint and the muscles which bring about those movements. So please remember, retraction, temporal. Clear? So this is about the movements of the temporomandibular. Now coming to inferior thyroid vein. Where is the drainage of inferior thyroid vein? So for there are three set of thyroid veins. So you draw thyroid gland something. Then this is internal jugular vein and this is brachiocephalic vein. So the superior and the middle goes into the anterior jugular vein, whereas the inferior thyroid vein goes directly into the brachiocephalic trunk. So it goes directly into the brachiocephalic trunk. So if you look here in this image, you can appreciate the superior going into the internal jugular vein, the middle going into the internal jugular vein, and the inferior going directly into the left brachiocephalic vein. Yeah. So this is the venous drainage of thyroid gland. Now, next question. All of the following structure passes through the substance of parotid gland except, now which of the following structure does not pass through the substance of the parotid gland? So here, one thing is, I think it should be very clear to all of you that the facial nerve, it travels through the substance of parotid gland and finally it divides into its 5 terminal branches. So facial nerve has to be remembered by everyone. Then the second structure which passes through the parotid gland is the retromandibular vein. And third structure related to parotid gland is the external carotid artery. So the answer here is internal carotid. So if we take a transverse section, now this is the left side, right? So this is the left parotid gland. Help you to understand. This is left transverse section. And we are seeing from above, right? So you can clearly see that the facial nerve is traveling all the way. This is facial nerve, right? And it travels through the substance of the parotid gland and then it divides into its 5 terminal branches. Number 1. Number 2, you can see the retromandibular vein. So this is retromandibular vein. And third, you can see the external carotid artery. So 3 structures you can see in relation to the parotid gland. And of course, if you look little medially, you can see the internal carotid artery here, the internal carotid artery, which is nowhere related to the carotid. The answer has to be internal carotid artery. But please do remember 2 structures. One is actually obviously the facial nerve, which divides into 5 terminal branches, and retromandibular vein. Retro means, the word retro is behind. Mandibular, now this is the mandible, the mandible. The vein is behind. So this is parotid. Please remember facial nerve, retromandibular vein, and external carotid artery in relation to the substance. Now next question, a patient has road traffic accident and yes, Raghu, absolutely right. Patient has road traffic accident and then he had extradural hemorrhage and there is rupture of middle meningeal artery. So the landmark which is related to the middle meningeal artery is perion, and I think most of you must be knowing that perion is an H-shaped area, and this is one of the weaker areas of skull. And many times you must have seen that whenever someone wants to commit suicide by a pistol, they usually keep the pistol right on the perion. So, and also during surgeries, whenever we have to make the burr holes, we prefer this approach because it is quite easy for us to get into the inside of cranium, right? So pterion is one of the weaker areas, and this is related to the middle meningeal artery. So whenever there is a fracture of pterion, there are chances that there is injury to middle meningeal artery resulting in extradural hemorrhage, right? Now, the middle meningeal artery, it passes through which foramen? Can anyone answer? It passes through which foramen? Anyone? Passes through foramen. Now, the other, and obviously this condition is extradural, also known as epidural hemorrhage. That is one thing. We can just take the opportunity to discuss few words about subdural hemorrhage as well. Very good, Raninda, very good. So, subdural hemorrhage, what is the source? This is venous. So, epidural, extradural is arterial, subdural is venous, and there is tearing of the emissary, or what we call bridging veins, right? So, this is subdural, below the dura mater, and this is epidural, just above. And the source, epidural is arterial, subdural is, yes, very good, bridging veins. Now we can move on to the next question about trigeminal nerve. It supplies all the following muscle except. So which of the following muscle is not? Very good, very good. Raghu, you are absolutely right. Stylohyoid muscle is not supplied by cranial nerve fifth, but you are wrong about its nerve supply. Stylohyoid is supplied by which nerve? Stylohyoid is supplied by cranial nerve seventh, that is facial nerve. Anyway, no problem, please correct yourself. So your answer is right, but difference is needs little correction. Stylohyoid, it is supplied by Malika, yes, absolutely you are. Stylohyoid, it is supplied by facial nerve, right? Then lateral pterygoid, medial pterygoid, tensor valli palatini, all are supplied trigeminal. Next question. Now, old woman having a large abscess in the middle of the right posterior triangle, and for which incision drainage was done, but post-operatively she could not extend her right hand above her head to comb her. So it means she can't do something like this. So this movement was gone, especially after a surgical intervention in the posterior triangle of neck. Which structure might have been damaged? Any idea? Very good. The answer is exactly right. Sertraline, you are right. Raghu, you are also right. So there is a cut injury to the spinal accessory nerve, and there is, see, spinal accessory nerve supplies only two muscles. What are those two muscles? One is sternocleidomastoid. Of course, the second one, all of you have answered right, that is trapezius. What is the action of sternocleidomastoid? Any idea? Yes, Raghu, absolutely right. What is the action of sternocleidomastoid? It is turning the neck. You want to turn, sternocleidomastoid helps. And what is the action of trapezius? Shrugging of shoulder is one. Shrugging of shoulder is one. And second is, yes, Aninda, you are right. Sertraline, you are also right. Trapezius, one is of course shrugging movement, lifting the shoulders up, and second is overhead abduction of arm, or what you call it, shoulder joint, right? So beyond 90 degree. What do you say? Beyond 90 degree or up to 120. This is done by trapezius and supported by serratus anterior, right? So whenever there is a cut injury to spinal nerve, sternocleidomastoid movement will be gone, and also the action of the trapezius, that is shrugging of shoulder, as well as overhead abduction, will also be gone, right? So in this particular case, the description is about the involvement of trapezius muscle as such. Yes, Aninda, you are right, more than 90, but up to 120, right? So please make sure that it is only up to 120 degree, because beyond 120 degree, there is a scapular rotation. There is no role of muscles as such. So I think we can take the shoulder abduction, a little bit of shoulder abduction also, because this is one very unique concept where different range of action, different muscles are involved. Usually this is not seen in any other joint, right? If I say 0 to 15 degree, any idea which muscle brings about 0 to 15 degree at? Yes, Raghu, absolutely fine, absolutely fine. 0 to 15 degrees supraspinatus, then 15 to 90 degrees deltoid, 90 to 120 degrees trapezius supported by serratus anterior, and 120 to 180 degree is scapular. Clear? So it's a unique concept, because otherwise at any other joint we never see this kind of differentiation in terms of the ranges of movement, right? So this is important. So this 90 to 120 degree shoulder abduction will be lost if there is injury to the spinal accessory nerve. Now next question, this is very, and again repeated so many number of times. Again you will see the push injury, and there is injury to the anatomical snuff box. Which bone might have fractured? I think everyone can answer this. Yes, yes, yes. Rinkesh, Raghu, Satrin, Varun, Maulika, Nilesh, Rubik. Absolutely everyone is spot right. And here the anatomical snuff box. What are the boundaries of anatomical snuff box? Any idea? Medially, laterally, Rajat bhai, namaskar, namaskar. Anyone, boundaries of anatomical snuff box? Aninda, you are absolutely right. Medially, it is extensor pollicis longus, right? So this tendon is extensor pollicis longus. See here, the prominent tendon is extensor pollicis longus, and this is medially. Right? So just make sure that you mark it right. This is medially, so this is extensor pollicis longus, and laterally you have the two tendons. One is extensor pollicis brevis and abductor pollicis. So these are the boundaries of anatomical snuff box. And why we teach so much about anatomical snuff box? Because whenever the patient has a fush injury, fall on outstretched hand, there might be injury to the scaphoid. There might be the fracture of a scaphoid, and that presents as tenderness in the anatomical. So the clinical pearl is that if you see a case with push injury and complaining of pain at wrist, and if you can elicit tenderness in anatomical snuff box, X-ray might be normal, right? So don't get deceived. X-ray might be normal. Simply based on the fact that there is tenderness in the anatomical nerve box post push injury, it is a very clear cut case of fracture, right. So if you find tenderness in the anatomical nerve box, you can simply say, yes, Sertraline, absolutely right. Ninda, you are also right. So fracture scaphoid. So this is a clinical diagnosis. What I mean to say, it's a clinical diagnosis. Very rarely in orthopedics, without X-ray, you make a diagnosis. So this is one of those fractures where even if X-ray is normal, just the clinical presentation is suggestive of fracture scaphoid. And X-ray might take around 10 to 14 days to show you the typical fracture line once there is bony resorption. Otherwise, this much presentation treated as a case of fracture scaphoid. And yes, Sertraline, you absolutely right. We can give a cast in class holding position, and Aninda is also right. One of the complication is avascular necrosis. Complication can be right. So this is in short about scaphoid and its relation or its importance in terms of tenderness at anatomical nerve box. Yes, absolutely right, Dr. Arya. Let's move on to another question. Nerve supply of supinator is like which of the following? So here again, this is a two-step question. Firstly, you should know the nerve supply of supinator. Then you should know the nerve supply of all the four muscles given. Then only you can correlate that, okay, the nerve supply of supinator is same as that this particular muscle. Certainly, you are absolutely right. The nerve supply of supinator is radial nerve, and yes, certainly you are absolutely right. This is brachioradialis, which is also supplied by radial nerve. So these two muscles are having the same nerve supply. Now, what about the nerve supply of brachialis? Any idea what is the nerve supply of brachialis? Anyone? Brachialis, what is the nerve supply of brachialis? Sertraline, perfect, perfect, yes. Brachialis, then coracobrachialis and biceps brachii. Brachialis, coracobrachialis and biceps brachii. All these three muscles are the muscles of the anterior compartment of arm, and all the three muscles are supplied by musculocutaneous. Very good, Dr. Arya. Right? So you can remember the mnemonic BBC, biceps brachialis, coracobrachialis. Remember? So anyway, this question is, I think everyone will remember it. Thanks everyone. Now coming to the nerve supply of deltoid, I think it's quite easy. All of you can answer. Very good, Raghu. So this is axillary nerve, and of course the other muscle which is supplied by axillary nerve is the teres minor. So these are the two muscles which are supplied by axillary nerve. Now, why I have kept this particular question? I just want to talk a little bit about the deltoid muscle as such. So deltoid muscle is, yes, right. So deltoid muscle is responsible for the rounded contour of, whatever the rounded contour of shoulder is visible, that is because of prominence of the deltoid muscle. Now it is supplied by axillary nerve, and there are two ways of seeing the injury of axillary nerve. Anyone? What are the two ways in which axillary nerve can be injured? One is, we have already discussed while we were discussing, very good, anterior shoulder patient, and there is one fracture. Any idea what fracture? Yes, perfect, certainly in Raghu, very good. That is fracture of surgical neck. So these are two possibilities when there can be injury to the axillary nerve. This is post-traumatic. There is, yes, Aninda, it's fracture surgical neck, very good. Arya, perfect. There is one more possibility if you give the intramuscular injections of the deltoid wrongly and if you directly poke the nerve. That is another possibility. But these are the two which commonly see in clinical practice: anterior shoulder dislocation and fracture neck of. Now coming to the clinical presentation of axillary nerve injury. As we know that it supplies deltoid, so the very first thing would be there would be loss of, very good. So there would, very good, there will be loss of rounded contour, and what we can see, we will see the bony prominences. We can see the lateral end of clavicle, acromion process. So bony prominences will be seen. Okay, so this can be correlated because that muscle cover is lost. Yes, Malika, absolutely right. I'll come to that. So there is loss of rounded contour, and that is makes the bony prominences are seen, and sometimes this is known as flat shoulder also. So this is one thing. Then of course, if the axillary nerve is gone, the deltoid is paralyzed, patient will not be able to do 15 to 90 degree of shoulder abduction. Clear? This we have already discussed. Like patient will say that I can lift up to 15 degree, but I will not be able to take it up to 90. And yes, if you passively take it up to 90, he will take it to 120 or even further. So that 15 to 90 degree range is gone. And third, yes, Malika, you are absolutely right. The axillary nerve, it gives sensory innervation to a small area on the lateral aspect of arm, right? A small area. So what will happen if the nerve is gone? You touch, patient will not feel anything. Right? So there will be anesthesia. There will be no sensations. And since that area is the place where the army people or the police people, they keep their regimental badge, so that particular sign has been known by the name regimental badge sign, right? So that is the reason why we call it regimental badge. Clear? So that is the reason why we call it regimental badge sign. So these are all manifesting axillary nerve LC, which are clinically detected as paralysis of deltoid nerve, and also the regimental badge sign. Okay? So please remember this much. Now we can move on to the next question. There is weak flexor pollicis longus and weak flexor digitorum profundus of the index finger. Which nerve could be involved? Yes, absolutely, absolutely. All of you are right. This is median nerve. Right? Now, I'll define it a little bit more. Now, there is flexor pollicis longus, right? FPL. So, pollicis means thumb. Any word, the moment you find pollicis, yes, thank you everyone. All of you are correct. Rinkesh, Rubik, Chiki, Aninda. Yeah, Aninda, you are absolutely right. So, flexor pollicis longus, that pollicis means related to thumb. Now, can anyone tell me the exact nerve supply of flexor pollicis longus? It is actually a branch of median nerve. So, this is actually anterior interosseous Clear? So this is actually anterior interosseous nerve, which is of course a branch of median nerve. And apart from this, there are two more muscles. One is pronator quadratus and third is flexor digitorum profundus. Now these three are the deep compartment muscles of forearm. Flexor aspect, right? So these three are the different deep compartment muscles of forearm, and all three are supplied by anterior interosseous nerve. The parent nerve is of course median nerve. So since we don't have AIN in the options, so we will go with the median nerve. That's perfect, right? So and in the rightly said, FDP has two parts, lateral part and the medial part. Lateral part is actually AIN and medial part is ulnar nerve, right? So lateral part will supply index finger and the middle finger, and medial part will supply the ring finger and the little finger. And therefore, the question is specifically mentioning the index finger only. So it means there is FPL and lateral half of, so this is actually lateral half, right? So the moment you have this kind of picture, you can say the answer is either AIN, and if AIN is not in the option, then you can mark. So please remember this much, don't mix up. Now, sartorius muscle originates from, yes, anterior superior iliac spine. Very good, Sertraline, very good, Raghu. Anterior superior iliac spine. Yes. So in short, we write it as ASIS. Now, I just want to discuss few facts about sartorius muscle. Yes, anyone can answer what is very unique about sartorius muscle? Yes, anyone? It is the longest muscle in the body. One thing, it is the longest muscle. Taylor's muscle, very good. It is also known as the Taylor's muscle. And then origin, we already discussed in the question, the origin is anterior superior iliac spine. Then what about insertion? What about insertion? Yes, Aninda, absolutely right. What about insertion? Medial part of tibial condyle. So medial tibial condyle, somewhere nearer to the, somewhere medial to the tibial tuberosity. So what I mean to say, now ASIS is somewhere here, and if this is tibia, so the muscle, it goes something like this, and it is inserted something like this. So it has a, you can say, a curved course kind of thing. Right? So what happens now? Based on this, we can discuss the action of the muscle. Very good. Flexes both hip and knee. Very good. So action are at both hip joint and knee joint. What is the action at the hip joint? One is of course very well said by Sertraline, so flexion. Here also flexion. Then anything else? Here it will do abduction and external rotation. Clear? So flexion, abduction, external rotation. But at knee joint, it will do internal rotation. Please remember, at one joint it is doing external rotation, at another joint it is doing internal rotation. So this muscle actually helps us in sitting cross-legged on floor whenever you want to sit. So these are the movements which occur, and this is controlled by sartorius muscle. So Now, any idea about nerve supply? What is the nerve supply? Any idea? Nerve supply, anyone? Anyway, it is femoral. Okay. So please remember this much about that. Yes, yes, sertraline, Saloni. Very good, very good. So please remember this much about sartorius muscle, and yes, it is a muscle of the anterior compartment of thigh along with quadriceps femoris. Right? We'll move on to next question. While eliciting patellar tendon reflex, which tendon is stretched? So this is a kind of deep tendon reflex. So which tendon is stretched? Very good. So this is quadriceps femoris. This is quadriceps femoris. Sertraline, no problem, no problem. Please don't mix up in words. So don't mix up with quadratus femoris, right? Now, as the name suggests, quadriceps femoris. Now, the word quadri means 4. So, the word quadri means 4. Here, this is actually 4. Now, can someone tell me what are the 4 muscles which are included in this muscle? Any idea? Yes, Aninda is right answer. What are the 4 components in quadriceps femoris muscle? It is quite easy. We have 3 vastus. Yes, there are 3 vastus. So, yes, sertraline, perfect, perfect. Chiki, you are also right. So, 3 vastus first, medialis, intermedius, and lateralis. Clear? So, these are the these are the 3 type of vastus. So, vastus medialis is one muscle, vastus intermedius is another muscle, and vastus lateralis is the third muscle. The 4th muscle is of course the rectus femoris. Clear? So, quadriceps femoris includes these 4. Number 1. Now, what is this quadratus femoris? Any idea what is quadratus femoris? Yes, Chiki, you are right. Rinkesh, you are also right. What is this quadratus femoris? This is a muscle in the hip joint. So, this is a short external lateral rotator of hip. Right? Please don't mix up quadratus with quadriceps. Yeah, number 1. Now, number 2, we'll come to the question proper. So, suppose is so this is the quadriceps muscle, okay, femoris. Then this is patella, and this is the real fibrosity, and this is the ligamentum. Is okay. So what we actually do, we stroke the ligamentum patelli, and because of that stretch reflex, there is contraction of the quadriceps femoris muscles, and there will be extension at the knee joint. So that is the normal knee jerk or knee reflex what we elicit, and this is a kind of deep tendon. Okay. So this is ligamentum patelli, which is a tendon of quadriceps femoris. I think this is a very basic question. Artery which is behind palpated behind medial malleolus. I think everyone can answer that. This is posterior tibial artery. Posterior tibial artery. Yes. posterior tibial artery. Now, this is important. A needle has to be inserted by an intern and it has to be inserted in the intercostal space. Now, what is the preferred site? What is the preferred site? Very good, Rinkesh. The answer is upper border of the hip. Now, why? Anyone can tell me why we prefer upper border of the rib and not the lower border of the rib? Any idea why we prefer upper border? For this, you need to know the anatomy of the rib. Now, in the lower part, there is one intercostal groove. So, there is intercostal, very good, Saloni. So, there is intercostal groove. In lower part, and through this intercostal groove, the neurovascular bundle is passing. The neurovascular bundle is lying here. Neurovascular bundle, right? So, the neurovascular bundle is related to the rib in this manner. So, suppose if someone is passing the needle this way through the lower end of the rib or the inferior surface of the rib, there are high chances of injury to the neurovascular bundle. High chances of injury to the neurovascular bundle. So, therefore, never advise anyone go along the inferior border of the rib. Always and always go along the superior border of the rib like this, right? So, upper or superior border of the rib, this is the safer area to introduce the needle into the pleural space, okay? Because of the arrangement of the neurovascular bundle in the lower part of the, yes, Saloni, absolutely right, neurovascular bundle, right? So, upper part is always preferred. Now, which of the following does not pass through aortic opening? Any idea? Now, aortic opening is not a true opening. It is an osteopneurotic. Very good. Everyone is right. Answer is phrenic nerve, right? So, the aortic opening is not a true opening and it is just a osteopneurotic defect on the posterior part, and through this, the main structure which passes through this is the, of course, aorta, then thoracic duct and azygous vein. These are the three structures which passes through the aortic opening. And yes, someone, Aninda, you are right, the vertebral level is T12. So, vertebral level, very good. Now, what is the importance of aorta passing through this osteopneurotic defect? Now, whenever we are discussing the openings in the diaphragm is a muscle actually, right? So, it helps in respiration whenever it contracts, inhalation, relaxes, exhalation. So, this opening makes sure that the point of passage of aorta remains unaffected with respect to the state of diaphragm. So, if the diaphragm is contracting, no problem, or no change in the size of the lumen. The diaphragm is relaxing, there is no change in the size of the lumen, and this makes sure that the amount of blood which is going from the thorax to the abdomen to the lower limbs, it remains uninfluenced. That is a very beautiful concept of this aortic passage through an opening which has nothing to do with the state of, so it remains uninfluenced. Now, taking this concept for esophageal opening. Now, esophageal opening is through which part of diaphragm? Any idea? Any idea? Esophageal opening is through which part of diaphragm? Yes, level is okay. Level is T10, Malika, level is okay. Which part? Like, see, diaphragm is a muscle. So it has two components, muscular part and a tendinous part. So the esophageal opening is through which part? In simpler terms, we can write it through the muscular part, right? It is through the muscular part. And why I am focusing on the muscular part? Yes, Malika, right? Why I am focusing on the muscular part? Because if you look at the anatomy, so the stomach contains and the esophagus doesn't have a mucosa which is well developed to tackle acid. So there is a mechanism by passing the LES through the muscular portion of diaphragm, because by the way of the tone of the diaphragm, this LES remains closed. So it acts as a pincher to keep the LES closed so that there is no gastroesophageal reflex. So this actually helps in preventing reflux. So I think this way you can understand that esophageal opening is through the muscular portion, because the tone of the muscular part of the diaphragm keeps the esophageal hiatus closed, and that prevents reflux of acid from stomach to clear. Yes, very good, Aninda, very good. So that will help you in understanding. And of course, the level is T10. Then apart from esophagus, there is left esophageal branch of left gastric arteries, they also pass through that. And the third one is the vena cava opening, which is through the central tendinous part, okay, through the central tendinous portion, which is at the level of thoracic vertebra. Okay. Right. So this is in short, and through this there is passage of inferior vena cava, phrenic nerves. So this is in short about the diaphragmatic openings, and it is very important because diaphragm is a, yes, Rubik, you are absolutely right. Saloni, everyone is right. So this is very important because diaphragm is a partition between the thorax and the abdomen. And some structures have to go from thorax to abdomen, or some has to ascend from abdomen to thorax. So it should give passage. But the most beautiful concept is about the aortic opening, which remains uninfluenced with the state of activity. Anyway, next question. Which of the following does not drain into middle meatus? Yes. Answer, which of the following does not drain into middle meatus in the lateral wall of nose? Very good, Malika. Yes, yes, everyone is right. Everyone is right. The answer is nasolacrimal duct. And nasolacrimal duct opens where? It opens in which meatus? is superior meatus. Right now, yes, very good. Nasolacrimal, very good, Molika. So nasolacrimal duct, it opens into the inferior meatus. Now here you need to remember three things first. Number one is the supreme meatus. What opens in supreme meatus? Is sphenoid sinus. And the second one which you should remember is the superior meatus. And what opens in superior meatus? This is posterior ethmoidal sinus. And the third one which you should remember is the inferior meatus. Very good, Aninda. Third one is the inferior meatus, and in inferior meatus there is opening of the nasolacrimal. Right. So principally remember these three: supreme meatus, sphenoid sinus; superior meatus, posterior ethmoid sinus; and inferior meatus, nasolacrimal duct. Apart from these three, whatever else is remaining, it will open in the middle. So that way, rest all opens. That will simplify the way of remembering. So I think this way you can understand it and remember it. Now in middle meatus, we have two landmarks. One is the hiatus semilunaris. This is the hiatus semilunaris, and on the top of that we have the bulla ethmoidalis. This is bulla. And in bulla ethmoidalis, there is opening of the middle ethmoidal. This is bulla ethmoidalis. The raised area is bulla ethmoidalis, and below that we have the hiatus semilunaris, which has got opening for maxillary, antiethmoidal, and frontal. Please remember like this. So if someone asks you what is the location of bulla ethmoidalis, then you can clearly say that it is in relation to the middle meatus, and there is opening of middle ethmoidal. Here, very good, everyone is perfectly right. Bulla ethmoidalis in middle meatus, and that has the opening of middle ethmoidal. Please remember. I think this will summarize the lateral wall of nose and the openings of. You can see here, this is bulla ethmoidal. Below this, have the hiatus semilunaris. Let's move ahead. A patient was operated on left submandibular gland, but accidentally his lingual nerve got damaged. So while operating on the submandibular gland, there is damage to the lingual nerve. Now what will be the clinical effect of this damage now? Yes, Molika, Saloni, yes, everyone is right. So there is loss of general sensations from the anterior two-thirds of the tongue on the same side. Yes. Now, anterior two-third, and on one side we can write base sensations and another is general sense. These are the Very good, Saloni. So, anterior two-third taste sensations are carried by tympani, and general sensation is carried by lingual. Okay. Whereas from posterior one-third of tongue, both the functions are done by same nerve, glossopharyngeal nerve. Okay. So, therefore, if there is any injury to the lingual nerve, it would lead to the loss of general sensation. Now, general sensation means cold, hot, touch. So, these are all general sensations. And taste sensation, of course, sweet. This is how the differentiation has been done for anterior two-third and posterior one-third. And now, we have discussed about the anterior two-third and posterior one-third. Now, how we demarcate, what is the point which, or what is that landmark which says that, okay, this is anterior two-third and this is posterior one-third. So, what is the point of demarcation of the anterior two-third with posterior one-third? So, this is circumvallate papillae. So, suppose if this is tongue, and this is anterior third, this posterior. So, this is the demarcation of anterior two-third from posterior one-third. Now, there is history of extraction of the third molar tooth, and after that, patient felt that there is loss of general sensation from the anterior two-third of tongue and floor of mouth. So, which nerve might have? I think everyone can answer this now. So, this is of course the lingual. Clear? So, general sensations, anterior two-third, please remember lingual nerve. Yes. Very good. Now, we know that palpate any artery, we have to press it against any base. So, there has to be a bony resistance against with that artery pressed so as to feel the palpations. Now, if you want to feel the palpations of common carotid artery, it should be pressed against Saloni. Yes, you are right. It should be pressed against the arch of cricoid cartilage. It should be pressed against the arch of cricoid cartilage. Like if you want to palpate the femoral artery, or if you want to palpate the radial artery, any idea? This is of course lower end of radius, and this is femoral. So the arteries, they have to be compressed against a bony background, then only we can palpate the pulsations. Now, all are paired cartilages in the larynx except. Anyone? Now, this is very basic. The answer is cricoid. So, it is, you can see this is cricoid cartilage here, all cricoid cartilage, and this thyroid. Cricoid is the answer. Now, this is important. Decussation of corticospinal What is the point of decussation of corticospinal tract? Any idea? Yes, very good. This is lower medulla. Lower medulla. And if you look at the anatomy of the medulla, you can see prominences like these. These prominences are actually because of the corticospinal. Here, they're all tracts on corticospinal. And these prominences are known as pyramid. So therefore, many places you might hear the word pyramidal tract. Pyramidal tract is same as that of corticospinal tract, because pyramid is the area of the medulla which is occupied by corticospinal tract. And yes, below this point, the corticospinal tract crosses to the other side. Over. So lower medulla is the point of decussation of the corticospinal tracts. And corticospinal tract, as the name suggests, going from motor cortex and reaching up to the anterior horn cells, spinal. So this is the upper motor part, and from the spinal cord there is origin of the peripheral nerves which forms the lower motor neuron. Right? So this is corticospinal tract. Decussation at the lower. What is the correct sequence of brain structures going outside to inside? Now, to understand this, yes, anyone? Anyone? Here is the insular cortex. See the and medial to this there is putamen, is medial to putamen is globus, yes, and globus pallidus is like putamen plus globus pallidus is lenticular nucleus. Right? So together these two are known as lenticular. And then we have the internal capsule here. Then this is all internal capsule here. Medial to internal capsule is the thalamus, and medial and superior to thalamus is the caudate. So, or you can just keep it should be superior and lateral. So we are going this way. Firstly, we will have the insular cortex. Then we have the lentiform nucleus, that is putamen and globus pallidus, an internal capsule, then the caudate nuclei, and finally the thalamus. Thalamus is the most interior This is A. So the answer becomes A. Yes, everyone is right. Be like this. So if we look in the image, this is the insular cortex, the lateral temporal, and then we have the putamen, putamen are the lobus pallidus externa and interna. Then we have the internal capsule. Then we have the caudate nuclei. This is always right. This is how, if we look in a coronal section. Okay, please remember. Now, not a feature of oculomotor nerve palsy. Now, before this, you should know the muscles which are supplied by the oculomotor nerve. So there is a mnemonic for that. SO4 R6 means the superior oblique supplied by cranial nerve fourth, lateral rectus cranial nerve sixth. Yes, everyone is correct. And all the remaining muscles, they are supplied by third, including levator palpebrae superioris. Now let us discuss the options. Levator palpebrae superioris, this is for elevation of upper eyelid. So if levator palpebrae superioris is gone, patient will not be able to do, there will be ptosis. So this is correct. Ptosis, this is because of paralysis of levator palpebrae superioris. Now, constriction of pupil is done by constrictor pupillae muscle, is supplied by third nerve. So if third nerve is gone, dilatation of pupil will be seen. This causes meiosis. And this is again light reflex, because what is light reflex? Light reflex, if you show light, there will be pupillary constriction. So afferent is cranial nerve second and efferent is cranial nerve, right? So if third is gone, there will be loss of light. So what is left now? Medial and upward. So again, medial gaze is by medial rectus, upward gaze is by superior rectus, which are both paralyzed because they are supplied by third nerve. So medial rectus and superior rectus, these are paralyzed, so this will not be seen. This will not be possible in a case of palsy. Yes, Raghu, you are absolutely right. Dilated pupils will be seen, and outward deviated eyes because of overactivity of outward and downward deviated because of superior oblique activity. So superior oblique muscle will depress the eye and will take the eyeball outward, supported by lateral rectus. Because in a particular structure, there is a balance between the agonist and the antagonist. If one muscle is paralyzed, the other group of muscles, they become overactive and they will try to pull the structure in their direction, right? So once there is paralysis of, you say, medial rectus, the lateral rectus will become overactive. It will pull the eyeball laterally. Once there is paralysis of superior rectus, inferior rectus, the superior oblique will become overactive and it will depress the eyeball. That is how Raghu said exact right words. Outward deviation of eye, and also you can add downward deviation of eye. That is the effect of. So this is all about paralysis of third cranial nerve. Now, next question: main branches of trigeminal nerve except. I think it is quite easy because we know that there are three branches of cranial nerve 5, cranial nerve 5-1, that is ophthalmic, cranial nerve 5-2, that is maxillary, and cranial nerve 5-3, that is mandibular. So yes, the answer would come out to be optic nerve, which is actually cranial nerve 2. Good. Now, next question. A patient has a swelling below the ear and he complained of pain in the lobule of ear, and then he cannot close his left eye completely and having difficulty in eating food. Which nerve is most likely damaged? Now here, firstly you have to understand there is a swelling below the ear, okay, and there is pain in the lobule of ear. So somewhat this is in discussion with the parotid gland, and one of the commonest tumor of parotid gland is pediatric adenoma, and we know that to the parotid gland we just discussed that there is passage of facial nerve. So, and this is one thing, facial nerve. Now secondly, if we discuss the features of facial nerve palsy, there is incomplete closure of the palpebral aperture. Palpebral aperture, because this is because of paralysis of orbiculus oculi, right? This is one thing. Then there is difficulty in swallowing. Then if you look at the face, there will be drooping of the angle of mouth, difficulty in puffing action. So this all go in favor of facial palsy, and that is related to the parotid gland. So whenever there is a tumor of the parotid gland, yes, Monica, you are absolutely right. Unable to close eye, that goes more in favor of facial nerve. Absolutely right. So this is facial nerve. Now, continuing the concept, if there is a lower motor neuron lesion of the facial nerve on the right side, presentation would be seen. Element palsy, facial nerve, what presentation you will see? Yes, anyone? Yes, right side. Oh, absolutely well, absolutely right. So yes, Raghu, Sertalin, Malika, all of you are correct. So there is right-sided loss of wrinkles over forehead, and the right-sided corner of mouth goes down. So this I already told you, that is drooping of the angle of the mouth on the affected side. So what happens? This is lower motor neuron type of paralysis, and suppose if this is face, there will be affection of or paralysis of the same side. The same side will be paralyzed. So if we are discussing about right side, it means the right paralysis of half of the face. Okay. This is one thing. Number two, in relation to the angle of mouth, see, normally the angle of mouth should be something like this. But what happens whenever there is paralysis on this side, the opposite side muscles become overactive and they will pull the angle of mouth towards the normal side. So it goes up towards the normal side because of the normal muscles pull, and it is low on the affected. So this is angle of, again, this helps in diagnosing a lower motor neuron paralysis of facial. Again, you can see here in the image, the angle of the mouth tilted somewhat like this. The facial expressions are not possible. If you tell the patient to close the eyes, he will not be able to close the palpebral aperture completely. Yes, Malika, you are right. This is Bell's palsy. This is lower motor neuron type of paralysis. Now, what actually is this lower motor neuron paralysis? Is this like we have, so this is the motor cortex. Where is the nucleus of facial nerve? Facial nerve nuclei in mid pons. Pons. And the fibers which are coming from motor cortex to the facial nerve nuclei, these are all upper motor neuron. And these are also known as the corticonuclear corticobulbar tracts. And the facial nerve will emerge from here. And this all constitutes the lower motor going to the. So this is the concept of lower motor neuron. If the nerve proper is injured, that is, yes, Raghu, absolutely right, 5, 6, 7 neurons. So if the nerve proper is injured, that is lower motor neuron. If there is an involvement of the corticomotor tracts, that is upper motor. Right? So I'm just discussing lower motor neuron. This we have already discussed, inability to shrug and elevate the shoulder. Which nerve? Again, this is a function of trapezius, and we know that the nerve supply of trapezius is spinal accessory nerve. So the point we have already discussed. Raghu, you are absolutely right. Yes, we hurry, you are perfect. Now, which joint is involved in looking right or left? Any idea? Or in other words, movement of no. You want to say no? This is, yes, right. Is pivot joint. And which joint actually is this? This is, so it's a pivot kind of joint and movement of no. So I think we can take short break. You either. Hello dear students, welcome back. In this session we will start with MCQs of ENT. Right? So taking the very first MCQ, in which a old male patient presented with merciful anosmia, wide roomy nasal cavity with formation of crusts and nasal obstruction. What is the diagnosis? Now here, if you look, there is one term, that is merciful anosmia. Now, anosmia means no smell sense. And why we call it merciful? Because what happens, there is emanation of very bad smell from the nostril of patient. There is emanation of very bad smell from the nostril of patient, and since there is anosmia, he or she could not smell that, and whenever they meet with anybody else, they all ran away. So they are not able to understand why people are running away from me. So that is because of this anosmia, and since they could not understand the reason why, so this is known as merciful anosmia. So this merciful anosmia, yes, everyone is right. Everyone is right. So this merciful anosmia is a typical feature of atrophic rhinitis. There is formation of crust within the nose. The nasal cavity is very wide. We call it roomy nasal cavity, and of course the classical merciful anosmia. So this is atrophic rhinitis. Yes, Raghu, absolutely right. So this is merciful anosmia. Now going forward to the next question, an elderly patient, bilateral neck swellings, temporoparietal neuralgia, and unilateral conductive deafness. So what does this suggest? Very good. This is a classical description for nasopharyngeal carcinoma, or what you call NPC, and there is a Trotter's stride. What are the components of Trotter's stride? Anyone? What are the components? What are the three components of Trotter's stride? U has been already given in the question. One is temporoparietal neuralgia. Good. Absolutely right. There is palatal palsy and conductive hearing loss. Very good. So these are the three contents in the Trotter's stride, very suggestive of nasopharyngeal carcinoma. So the moment you have this kind of presentation, it's very easy to make a diagnosis of nasopharyngeal carcinoma. And here you are getting this word also, like bilateral neck swellings. What is this? These are actually enlarged lymph node. So this is a classical description for nasopharyngeal carcinoma, or what you call NP. Then moving ahead to another question, unilateral nasal obstruction with blunt stage charge in a child. Any idea what is this? Yes, Raghu, you are absolutely right. If in a child you have this kind of history, then it suggests there is neglected foreign body. So a neglected foreign body will have this kind of presentation, unilateral nasal obstruction with blood stained discharge. For a child, always remember neglected foreign. Yes, Aninda, Nilesh, Raghu. Yes, foul smelling. Yes, very good. So this is a typical presentation for neglected foreign body in a child. Now, which of the following is not seen in Meniere's disease? Which of the following is not seen in Meniere's disease? Yes, anyone? Yes, Raghu, Aninda, Shivendra, everyone is right. The triad of Meniere's disease is also known as endolymphatic hydrops. We will see there is vertigo and there is tinnitus and there is sensory neural hearing loss. So the answer comes out to be loss of consciousness. It is not a feature of Meniere's disease at all, right? So vertigo, tinnitus is ringing of ears, and sensory neural hearing loss. Perfect. So this is Meniere's disease. Then next question, a patient hears better in noise. Now what is this known as? Yes, perfect. Raghu, you are absolutely perfect. So a patient hears better in noise. This is known as paracusis willisii, and this is a feature of otosclerosis. Right? So in otosclerosis, we will find paracusis willisii, and that is really patient hears better in noisy surroundings. That's so because a person or the fellow who are surrounding the patient, because they are in a noisy environment, so they will speak a little louder, and the patient takes the advantage of that, and therefore he is able to listen them in a better way as compared to the usual way of talking, right? So in noisy surroundings, patient hears better, but if the silent are quiet and if people are speaking in a low volume, then it is very difficult for the patient to understand things. So this is known as paracusis willisii, a very characteristic feature of otosclerosis. Next question. 55 years old male, a known case of diabetes with poorly controlled blood sugar, developed right facial nerve palsy, and also he is having pain in right ear and discharge from right. On examination, granulation tissue was found in the external auditory canal. What this suggests? Yes, Pradeep, absolutely right. Sudhir, Raghu, everyone is right. Yes, yes. So this is presentation of malignant otitis externa. Now here one should remember few things about malignant otitis externa. We are getting this word malignant here, but this is actually misnomer, right? So it is not a malignancy, right? It is not a malignancy. It is just that the infection is very severe. So we have used this word malignant, but it is not a malignant entity at all. This is most commonly caused by, yes, pseudomonas, rightly said, and especially seen in cases of poor blood sugar control in diabetic mellitus or immunosuppressive condition. So in those conditions we see this infection of the external ear, and since this infection is very severe, so we use the word malignant otitis. Yes, Raghu, you are absolutely right. It is not a cancer, and therefore this word malignant is actually a misnomer. Right? So this is caused by pseudomonas, especially in immunosuppressive states or poor sugar control in case of diabetic, and it might involve facial nerve as well. So this is malignant otitis externa. Now, can anyone tell me what bacteria is responsible for causing simple otitis externa? Anyone? Because malignant, it is related to pseudomonas. Which bacteria is associated with simple otitis externa? Anyone? This is Staphylococcus. So this is Staphylococcus aureus. Commonly, it is Staphylococcus aureus. Now, what is this term? Chronic suppurative otitis media. Here, if an acute infection is not treated properly, it might go into CUSOM, and again CSM can have two presentations, safe and unsafe. Right? Safe and unsafe. In safe, the perforation is central perforation, and in unsafe it is, you can say, marginal or equiantral. And there are high chances of cholesteatoma in unsafe variety, and this cholesteatoma is actually a bony erosive. Right? Yes, Ghosh, you are absolutely right. Equiantral is unsafe actually. Okay, so this is in short about CUSOM, that is chronic suppurative otitis media. Now going onward to next question. Elderly male presents with hearing loss, pulsatile ringing sound in the ear for the last 3 years, and on otoscopic examination we can see a pulsatile reddish mass behind the tympanic membrane which is intact, and this mass blanched and stopped pulsating on applying pressure with Siegel's pneumatic speculum. Most likely diagnosis. Very good, Raghu. This is glomus tumor. So this is a vascular entity, and the characteristic feature is a pulsatile reddish mass behind the intact tympanic membrane, and if we put pressure, it blanches. Blanches means it becomes pale. So this is a classical presentation for glomus tumor. Very good. Now next question. An elderly diabetic male with uncontrolled sugar presented with dyspnea, fever, generalized malaise, and respiratory rate was increased. Nasopharyngeal swab for RT-PCR was positive for SARS-CoV-2, and later on he developed swelling in both in the periorbital area bilaterally with proptosis of right eye. Which microorganism can be the reason? Yes, the description is for which condition? Clinical presentation is for mycosis. Of course, the responsible agent is mucor. Yes, everyone is right. Sudhir, Shivendra, Raghu, Chiki, Pradeep, Sanjay, Pradeep. Thank you. Everyone is right. So this is a classical presentation of mucormycosis, especially related to COVID infection, and here we can see involvement of the periorbital area along with proptosis. Now, what is this proptosis? Projection of, or you can say prominence of the eyeballs. That is known as proptosis. So this is mucormycosis. which is treated by amphotericin B injections. Coming on to the next question, multiple perforation of tympanic membrane is characteristically seen in. Yes, anyone? Multiple perforation of tympanic membrane. Anyone? Yes, Avya, you are right. This is tubercular otitis media. So in cases of tubercular otitis media, you can see this is one perforation, this is second, here you can see the third, this is multiple perforation of panic. This is classical for tuberculosis. So tubercular otitis media. Now what we see in case of serous otitis media? Any idea what we see in cases of serous otitis media? Serous otitis media, which is also known as blue ear or otitis media with effusion. Yes, very good. So this is actually air fluid levels. Yes, we will see air bubbles. So air fluid levels will be seen. Very good. And in case of acute suppurative otitis media, what we will see? Cases of otoscopic examination. Any idea? We'll see a congested and bulging tympanic membrane. Very good. Right? So congested and a bulging tympanic membrane. In cases of CSM, we will see a perforation in the tympanic membrane. It can be in central or aticoantral region. So this is how we can see either in so few words about typical appearances of otoscopic examination options. Then next question, a patient had a history of head injury and he developed unilateral conductive hearing loss, but tympanic membrane was normal and it was fully mobile. Now what could be the cause of this conductive hearing loss? Anyone? See, whenever we are discussing conductive hearing loss, very good, everyone is right, So whenever we are discussing conductive hearing loss, there are a few points which you should remember. Number one, either there can be a problem in the tympanic membrane or problem in middle ear cavity or problem in ear ossicle. Please remember at least these three important reasons for conductive hearing loss. So tympanic membrane, middle ear cavity or ossicle. Now since here the tympanic membrane is normal and fully mobile and there is a history of head injury, so it goes more in favor of the dislocation of the incudostapedial. So this is how we can just, by the principle of exclusion, we can reach up to the answer. There is history of injury, so that what is more in favor of the disarticulation of the middle ear. So this is just because of head injury. ASM can also lead to conductive deafness, but there will be a history of fever, heaviness, pain in the ear, right? So this is eighth nerve injury that will always lead to sensory neural hearing loss, right? So this is how we can just rule out the options and we can choose the best possible answer. Yes, everyone is correct. C seems the better answer here. Next question, most common clinical presentation of acoustic neuroma, which is also known as vestibular schwannoma. Yes, anyone? Now, this is a tumor of cranial nerve 8th. Therefore, the better answer would be cochleovestibular symptoms. Right? It is a tumor of cranial nerve 8th, so it will present with cochleovestibular symptoms. Next question. A diabetic lady presented with destruction of the nasal portion or face, and she had a past history of COVID-19. So, what drug can be given? And I think most of you can make a clear-cut diagnosis that this is a case of mucormycosis. So, post-COVID, yes, everyone is right, perfectly right. So, mucormycosis, we can give injection amphotericin B. Yes, right. Raghu, Chiki, Shivi, everyone is right. So, destruction of the lateral part, post-COVID mucormycosis, and should be treated by injection amphotericin. Now, this we have already discussed before, not a component of Trotter's pride. I think everyone should be able to answer this. We have already discussed this. So, not a component of Trotter's pride. Yes, Raghu, Nilesh, both of you are correct. Answer is facial nerve palsy. So it is not a, there's nothing to do with Trotter's pride. So we can see soft palate immobility is actually is nothing except palatal palsy, temporoparietal neuralgia, and unilateral conductive deafness. So classical triad for nasopharyngeal carcinoma. Please don't. Right. Now, stylalgia may present with ear pain. Which nerve may refer the pain to middle ear? Anyone? Yes, Raghu, you are absolutely right. This is glossopharyngeal nerve, and glossopharyngeal nerve is actually the nerve supply of middle ear and medial aspect tympanic membrane also. So stylalgia, one condition which is also known as Eagle's syndrome, where there is elongation of the styloid process. There can be irritation of the glossopharyngeal nerve, which can refer the pain to the middle ear. Right? So this is Eagle's syndrome, stylalgia. Next question: a 5-year-old child presented with nasal discharge and nasal obstruction. There is history of recurrent infections, and the child was breathing from mouth with a high arched palate. What can be the diagnosis here? Yes, everyone is correct. To Shivendra, Ganesh. This is adenoid hypertrophy. So this is adenoid hypertrophy, and the child is breathing from mouth. It means the adenoids have enlarged and they have obstructed the airway. So the child finds it's very easy to breathe from the mouth. So this is adenoid hypertrophy. Now, the important thing here is that adenoid hypertrophy here, if the child is breathing from mouth, it means there will be no proper aeration of maxillary sinus, right? And this will lead to poor development of maxillary sinus or the maxillary prominence. Right? This is number one. Number two, these patients can have an associated otitis media. Which type of otitis media? This serous otitis media. So these patients, they can have glue ear, right? And therefore, whenever we are treating these patients, we have to take care of this serous otitis media also if it is present. So for that, we need to do maryngotomy with a grommet tube along with adenoid. So we have to treat the condition as a whole. So if there is adenoid hypertrophy, do an otoscopic examination. If you find there is serous otitis media, it has to be treated simultaneously, right? Now this is very important because if you neglect adenoid hypertrophy and the child continues to breathe from mouth, later on he might have very depressed kind of nose because the LR nasi are not used properly. Then he will have adenoid facies, proper adenoid facies. So this is very problematic and should be addressed timely. Yes, Raghu, you are absolutely right. Serous otitis, glue ear, perfect. So treatment wise, we need to remove the adenoid. Plus, if there is glue ear, we have to address that as well. So myringotomy, here treat the whole complex as one entity. Next question. Appropriate investigation for JNA, juvenile nasopharyngeal angiofibroma, and Raghu said yes, you are right that biopsy is contraindicated, but the best answer is TCT head. And here we will see one clinical sign that is known as Ullmann-Miller's sign. Now what we'll see here, suppose if you are looking you are having a transverse section, so this is suppose the outline of maxillary sinus. So what will happen, the tumor which is present here, it will push the posterior wall of the maxillary sinus. So you will see something like this. This is the Ullmann-Miller sign, which says that there is a thing of the posterior wall maxillary sinus by the. So we can compare it with the other side. Yes, Ullmann-Miller sign, very good, Ganesh, right? So CCT is best, and of course Raghu pointed out very nicely that biopsy is contraindicated since it is a highly vascular. Don't go for biopsy, otherwise it will keep on bleeding. So this is juvenile nasopharyngeal angiofibroma, which is better visualized or evaluated on CECT head. Yes, very good, Aninda. There is anterior bowing of posterior. You can call it perfect. Next question. Causative agent for NPC. I think everyone knows this. This is Epstein-Barr virus. No, this is very interesting. Weber test, conductive deafness. Nilesh, Iki, Ninda, yes. All of you are right. Extreme, yes, absolutely right. Sound louder in diseased ear. Now here, what we do actually in Weber test, we tap the tuning fork and we will place it on the center of forehead. Tap, place off, and then you need to ask in which ear the patient is hearing better, right? Or in simpler terms, where is the lateralization? Is it going to one particular ear or it is same on both the sides? Ask for lateralization, if any. Right? In a normal person, normally no lateralization. It should be heard equal in both the ears. But suppose if the patient is having problem in right ear, and when you do Weber test, the lateralization is towards the diseased ear, then you can say that in right side there is conductive hearing loss. So diseased ear, lateralization, conductive hearing loss. If the patient is complaining of problem in the right ear and you find that lateralization is going on to the left side, it means there is sensory neural hearing loss in the. So lateralization, same side CHL, opposite side sensory neural hearing, right? So if the patient is coming to you with some deafness in right ear, you do Weber test. If the lateralization is going to the right side, you can say that this deafness is probably conductive hearing loss. But if patient is having deafness in the right side and lateralization is going towards the left side, then you would say that on the right side there is sensory neural kind. So based on Weber test, we can ascertain what kind of deafness patient is having. So this is, if conductive deafness, same side. Sensory neural deafness, just remember this man. So if we look at the diagram, we are keeping the base of the tuning fork somewhere here like this, and then we tell the patient to close the eyes and tell us which side sound is going more. We are actually checking for lateralization. And normally it should be equal on both sides, right? So patient will say, I'm having the sound both same type in both the ears. But suppose if there is problem in right ear, okay? Suppose if there is problem in right ear and the lateralization is going also onto the right side, then you will say, then in the right ear there is conductive hearing. Now, if suppose the problem is the right ear, but patient is saying that I am hearing better or I am having lateralization in the normal side, then you will say that the right side is having sensory neural hearing. So this is how we interpret the Weber test, whether a person is having conductive hearing loss or sensory neural hearing. So next question. 16 years, male, epistaxis, red mass around the nostril. Yes, very good. So this is JNA. The moment you find this particular presentation of a adolescent male with fullness in cheek, recurrent epistaxis, straightforward, make a diagnosis of JNA, juvenile nasopharyngeal angiofibroma. So there should be no confusion in this particular entity. Now again, one more tuning fork test, Rini test. Rini test is positive in. Yes, anyone? Very good, Raghu, very good. So Rini test is positive in normal ear. Yes, push, please. Everyone is correct. Now, what actually this Rini test is? So, what we do in Rini test? Firstly, we tap the tuning fork and we will keep it over the mastoid, right? And we will tell the patient, the moment you don't hear any sound, please tell me. And as soon as the patient tells you that I am not hearing any sound, you will lift the tuning fork and you will place it in the front of external ear. And normally, a person should be able to hear the vibrations when it is kept in the canal or external auditory meatus. Now, when we keep the tuning fork over the mastoid process, we are checking bone conduction. And when we are keeping the tuning fork nearer to the external auditory canal, we are checking air conduction. So, in a normal person, air conduction is always more than bony, right? So, in a normal person, air conduction is more than bony conduction, and this is known as positive Rini test. Number one. It means when the patient will say that I am not feeling any bone conduction, you will take out the tuning fork and you will keep it in front of the external auditory meatus. Normally, a patient should appreciate the vibration. But this is not only limited to a normal person. The same thing can also be seen in sensory neural hearing loss. In a person in whom there is sensory neural hearing loss, you will find that bone conduction is shorter and air conduction is more. So, air conduction is more than bony conduction. So, in both the cases, normal as well as sensory neural hearing loss, air conduction would be more than bony conduction, and you will say that the Rini test is positive, right? So, if I say Rini test is positive, then of course one condition is normal ear, or else it can also be sensory neural hearing loss. Okay? Sensory neural hearing loss related to the inner ear and the 8th cranial nerve. So, in both the cases, bone conduction will be less, air conduction will be clear. So, I think there is no confusion in this. For the time being, we are limiting ourselves to the normal ear and the sensory neural hearing loss case where the air conduction is more. Conversely, if there is conductive hearing loss, just reverse the scenario. In cases of conductive hearing loss, bone conduction will be more than air, right? So, in cases of conductive deafness, there can be perforation, collection of fluid in middle ear, or there may be disruption of ossicles. In all such cases, bony conduction will be more than the air conduction, and then we will say that our test is negative. Clear? Please remember this one. Now, based on Rini test, we can take one more Good question. Which of the following is not true for Rinne's? Now you have to check which option is not true in relation to Rinne's test. Now we'll take the options one by one. AC is more than BC in normal year. You think this statement is correct? Yes. Okay. So this is the right statement. We just discussed that air conduction is more than bony conduction in normal ear and also in sensory neural hearing loss. So A and B options both are correct, and they suggest that it is a positive Rinne. Then coming to option C, BC is more than AC is conductive hearing loss. This is also true. Converse of what we have discussed in option A and B. So bone conduction is more than air conduction in conductive hearing loss. Now, by the way of exclusion, we can say that the answer is option. Right. Now, we will discuss what actually this option D is. Now here, the condition is severe sensory neural hearing loss or dead ear. Now here what happens, there is no air conduction as well as there is no knee conduction. So here there is no air conduction, and yes, Raghu, you are absolutely right, absolutely right. So what happens actually, like suppose you are checking the Rinne's test. So suppose this ear is dead ear. Right? So there will be no air conduction, there will be no bony conduction, but when you will do bone conduction, patient will feel the bony conduction because of the transmission from the opposite side. Right? So it is just because the opposite side transmission can take place through cranium, and therefore your bone conduction will be more than air conduction. So bony conduction will be more than air conduction because the transmission of sound is occurring through the cranium, right? So this is wrong because in the affected side there is no air conduction, there is no bony conduction as such, but since it is coming from the opposite side, so this is false, and of course BC more than AC is negative. This is false negative. Very well said, Raghu. So this is false negative actually, and if you want to eliminate that, what you can do, you can simply cover this ear, right, with a box so that there is no concept of bony conduction, and this conduction which was occurring before, it can be eliminated, right? So this is a beautiful concept related to dead ear or severe sensory neural hearing loss, where usually there is no air conduction, no bony conduction, but since the bony conduction is taking place across the cranium from the opposite side, so it gives a false reading as if the bone conduction is more air conduction, and since we know that bone conduction more than air conduction is negative test, but here we are getting it in a wrong manner, so we will use the word false negative. Clear? So this is option D, which is wrong. It should be false negative, or you can say BC more than AC in dead or severe sensory loss. Clear? Next question. Hyperacusis is seen in all except. Any idea? Hyperacusis is seen in all except. We just discussed one word, paracusis, and paracusis is a feature of autosclerosis. So in autosclerosis, please remember one term, that is para. There is no word like hyperacusis, it is actually paracusis, and we have already discussed what paracusis means. The patient hears better in noisy surrounding. think with that particular term, you would be able to get your answer. So here's better in noisy surrounding, that is paracusis. Yes, Raghu, you are absolutely right. Next question, I think we have already discussed this and can answer it perfectly. Malignant otitis externa, the answer has to be pseudomonas without any confusion. Yes, Raghu, you are right. Now, a child presented with ear pain and markedly congested tympanic membrane. What can be the diagnosis? Anyone? Pratik, that is hyperacusis, na? That is hyperacusis. Anyway, everyone is right as far as the answer to this question is concerned. And this is acute suppurative otitis media. And yes, if in this question, if we could have added some words like high grade fever with ear pain and markedly congested tympanic membrane, it is perfect, presentation of acute suppurative otitis media, which is principally seen in children. And here, what you need to do, anyone, what you need to do for ASM? See, whenever there is pus formation, if you don't, okay, Raghu, antibiotics will be given, yes, no doubt. But if there is pus formation and if you don't drain it, it will come out automatically after rupturing the tympanic membrane. So what you need to do? You need to do a myringo. Okay, so give a incision and drain the pus, of course, with antibiotic. But if the pus is formed, and antibiotics alone won't work, right? So that is myringotomy. Myringo is tympanic membrane. Tomy means giving an incision, right? So give an incision, let the pus come out, and under cover of antibiotics. If you don't do it, it will rupture, it will perforate automatically. So this is ASOM. Okay, next question. Most common cause of stridor in newborn. I think most of you will answer this absolutely right. Yes. Push, you are absolutely. Yes, so this is laryngomalacia, and you can see a typical, look at the shape of the epiglottis. This is omega shaped. Very typical of, yes, you are perfect. And yes, Raghu, it will resolve spontaneously. So in treatment wise, just reassure the parents because the condition will resolve spontaneously. Yes, perfect. This is related to neonates. And whenever the child inhales, there is, in drawing, you can say of this epiglottis, and this creates stridor. Okay? So this is the cause of inspiratory stridor in the newborn. Stridor in newborn. So laryngomalacia. This is good. Sensory nerve supply above the level of vocal cords. Yes, anyone? Suppose this is the level of vocal cords. above this and below this. Above this is supplied by, yes, Raghu, you are right. This is internal laryngeal nerve, and below this is supplied by recurrent laryngeal nerve. Yes, so there, yes, Nilesh, you are right. So the answer is internal laryngeal nerve. Now, internal laryngeal nerve, and there is one more. There is one superior laryngeal nerve. It divides into two branches: internal laryngeal nerve, and another is external laryngeal. Okay. So internal laryngeal nerve and external laryngeal nerve. Now, internal laryngeal nerve is providing sensory supply larynx above vocal cords. And yes, very good, Raghu. External laryngeal nerve is supplying cricothyroid muscle. Okay. So both the two are branches of superior laryngeal nerve, which itself is a branch of vagus nerve. So this is superior laryngeal nerve, which is coming from vagus nerve. Now, why we should know about why I am discussing this external laryngeal nerve here? Because there is a rule for nerve supply of the intrinsic muscles of larynx. And what is that rule? All muscles of the larynx are supplied by recurrent laryngeal nerve, except that exception is cricothyroid, which is supplied by external laryngeal. Clear? Please remember this statement. All the intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve, except cricothyroid, which is supplied by external laryngeal nerve. External laryngeal nerve is another branch of superior laryngeal nerve. Internal laryngeal nerve, of course, is supplying the area from the epiglottis till the vocal cords. This is all supplied by internal laryngeal nerve. So we can take a 15 minutes break, and then after the break we will start questions of ophthalmology. See you after 15 minutes. Welcome back, dear students. Now, in this session, we will take ophthalmology. So, the very first question is a chronic granulomatous inflammation of upper eyelid presenting as a painless swelling. Now, what is this? Yes, everyone is right. This is chalazion, which is actually the involvement of the which glands? Can anyone answer which glands are affected here? Very good. So this is affection of meibomian glands, which are actually oil secreting glands. Yes, away from lid margin. Very rightly said. Very good. And this is a painless condition as compared to sty, which is a very painful condition. This is a painless condition as compared to sty is painful and nearer to the border of eyelids. Okay. So meibomian gland affection, and you can see this is vertical swelling, chalazion, and treatment wise, what we can do in early stages, we can advise for hot, right? Because yes, Raghu, you are right. But before going for surgery, we should try at least a little bit of conservative measures, which includes hot compression, because we know that it is filled up of waxy material. So we just expect that if we do hot compressions, it might liquidify and come out. So we try with hot compression, yes, but if the condition is not responding, or if the patient presents late, then obviously we need to do the drainage. Patient is presenting late, then we need to use a chalazion clamp. We will give an incision and we will drain the things. Drainage. Perfectly fine. So this is the typical presentation for chalazion, and this is how we manage it. Now, next question. A child from low socioeconomic group, and he has foamy white spots over the temporal side of conjunctiva on both the eyes. So the description is actually for which condition? So the description is actually, yes, you are right. The answer is option D, that is vitamin A. And the condition which is actually discussed here is Bitots spots. Right? So the condition in discussion is Bitot spots, which are very well because A. Yes, Chiki, you are perfect. Deep, you are right. So this is vitamin A deficiency. Now, next question. Which of the following is not derived from surface ectoderm? Which of the following is not derived from surface ectoderm? Yes, anyone? See, crystalline lens is from surface ectoderm. Lens is from ectoderm. It's from surface Any other answer? Yes, Aninda, you are right. You are right. The answer is sclera, and sclera is derived from mesoderm. Okay, the sclera is derived from mesoderm. Please remember, and rest other all options, corneal epithelium or epithelium of lacrimal gland, they are all phase. Okay, so sclera is from mesoderm. Thank you, military world. Just your wishes and love, I am finally here. Anyway, so this is in short about embryology. Now, which area is known as the dangerous zone of the eye? Yes, absolutely right, Raghu. This is ciliary body, and I think most of you must be knowing why we call ciliary body as the dangerous zone of the eye, because if there is any penetrating injury in the region of ciliary body, which condition will result? Very good, Raghu, very good. This can result in sympathetic ophthalmitis. Okay, this is sympathetic ophthalmitis. Okay, so that's why this is known as the dangerous area of the eye. Now, you must know two more dangerous areas in the body, and one is dangerous area of face. Yes, anyone? And second is dangerous area of, yes, anyone? What is the dangerous area in face? Yes, Raghu, you are right regarding scalp. What about face? Very good, very good. So suppose if this is face, and then this all area known as dangerous area of the, this is the dangerous area of the face. It is a, yes, yes, absolutely right. Pratik, you are also right. So this is the dangerous area of the face, and why we call it dangerous area of the face? Because infection anywhere in this part can directly go to the cavernous sinus, and it can result in cavernous sinus thrombosis. Okay, that's why it is known as dangerous area of the face, because there is valveless communication. Here, valveless communication between the branches of the facial. Yes, yes, oh, absolutely right. So because of the valvulus communication between the facial veins and the cavernous sinus, so that infection anywhere from here, it can directly reach up to cavernous sinus, resulting in cavernous sinus thrombosis. Okay, so that's why any infection in this particular area should be promptly treated, and just to avoid any possibility of cavernous sinus thrombosis. Now, my question is, what is that important clinical feature which suggests possibility of cavernous sinus patient? Clinically, how you would suspect a given case has probably gone into cavernous? Any idea? If there is simultaneous involvement of, you are partially right. If there is simultaneous involvement of which cranial nerves? Third, fourth, and sixth, right? Because these all are lying in relation to the cavernous sinus, right? So if there is any involvement of cavernous sinus the form of thrombosis, these all nerves also get affected. And therefore, if you see a case of person with simultaneous involvement of third, fourth, sixth cranial nerve, yes, along with proptosis and other feature of cerebral cranial infection. Apart from that, in terms of nerve supplying the extraocular muscles, particularly 3, 4 and 6, think of cavernous sinus. That is a very unique situation where we see involvement of all the 3 nerves at one time. Otherwise, it is very rare to affection of all the 3 nerves. Right? So this is one important presentation which make us suspect the possibility of cavernous sinus. Yes, everyone is right. Aninda, Pratik, all everyone is right. Right. So this is dangerous area of face. I think this one is clear. Now we come to dangerous area of scalp, and yes, somebody already has already mentioned about this. Yeah, Raghu, you told about it. So if we yes, very good. So if we take the layers of scalp, what are the layers of scalp? S is for skin, C is for connective tissue, A is for aponeurosis, and L is for loose areolar tissue, and of course the fifth one is, yes, Raghu, perfect, is pericranium, or you can also write periosteum, right? So these are the 5 layers. Out of these 5, we are interested in discussing loose areolar tissue, because this is the point of connection between the extracranial and the intercranial veins, right? Yes, Prakshi, Prakshi, and you are absolutely right. So this is the loose areolar tissue, which is the dangerous area of the scalp, because the intracranial veins, they communicate with the cranial veins, and if there is any infection in this particular area, it can directly go inside the cranium, right? So that's why we consider it as a dangerous area. The infection can move inside the cranium. Okay, so please remember these dangerous areas of the body: eye, face, and scalp. Next question. Placido disc. Yes, Placido disc is used for detecting all except. Anyone? Placido disc. Anyone? A. No, it is done for A. A is we do it. We evaluate A. So this is right option. Any other answer? We evaluate astigmatism. We evaluate keratoconus. No problem. No, it's slightly difficult to answer. Actually, what we do in Placido disc, we actually look at the surface of the cornea. So if there is any abnormality in the surface of the cornea, obviously it would be reflected in the Placido disc. So just to make you understand the concept in a better way, you should look what actually we do in Placido disc. So normally if you look at the corneal surface through a Placido disc, it should show us a symmetrical and a spherical picture. So this is normal cornea, and if there is any distortion in the shape of the cornea, it may be because of keratoconus, it may be because of astigmatism, or even it is because of corneal scar, it will distort the image of Placido, right? So Placido disc, you can simply remember it is for corneal case, in simpler words, right? So therefore, we can exclude the microcornea from these options. And now, what actually microcornea is? What is microcornea? As the name suggests, micro means small. Any idea what is microcornea? This is small. So the the horizontal diameter of the cornea is about 10 to 11 millimeter. Right? So this is microcornea, and this can be measured by caliper or ruler. Right? So microcornea is a different entity, and it won't show any irregularity on the face of the cornea. Yes, it is a congenital anomaly. It may be associated with a flat cornea also. So as far as the placido disc is concerned, any abnormality in the surface or the curvature of the cornea, you can say, that will lead to the distortion of the image on the placido disc. Clear? And I think all of you must be knowing what astigmatism is. There is a spherical aberration, so that the rays of the light, they focus on different point on the retina through the cornea. And keratoconus, as the name is, the word conus is here. Now the word kerato is for cornea, conus is actually conical. So rather than, this is the normal cornea, and in keratoconus it becomes something like this. This is okay. So forward projecting conical type of cornea. Clear? So placido disc has no role, microcornea. Now next question. A child was hit while playing. He was hit in the eye, and later on he developed headache, diplopia on looking up, and enophthalmos, most likely diagnosis. Very good, Raghu. This is fracture floor of orbit. Now, before answering this question, we should take few words. Diplopia means double vision. Yes, Varun, you are right. And what is this word enophthalmos? Enophthalmos means, in simpler terms, you can understand it as sunken. So if there is sunken eyes, if there is diplopia, especially when the patient tries to look upward and associated with headache, post injury, this goes in favor of the diagnosis of blowout fracture. And yes, the usual type is fracture of floor of orbit. Rakshi, inward eye, it's like sunken eyes, right? You can say inward eye, but better is sunken eye. So this is a typical case history for blowout fracture. Now, enophthalmos you will also find in Horner syndrome. Enophthalmos is also a feature of Horner syndrome, right, Raghu? And what features you will find in Horner syndrome? Any idea? Apart from, okay, one is of course enophthalmos, sunken eyes. What else will you find in Horner syndrome? Any idea? Very good. Anhidrosis, meiosis. Very good. So one term is loss of sweating, that is known as anhidrosis. Then there is pupillary constriction, that is known as meiosis. Meiosis. Then there is drooping of upper eyelid. This is known as, and there is one more feature you can mention. Yeah, Raghu, you told it, like, yes, loss of ciliospinal reflex. Very good. That is loss of spinal. Now, what is this loss of ciliospinal reflex? Actually, what happens if you pinch at the nape of neck, there should be pupillary dilatation. Now, what is the cause of Horner syndrome? Any idea? What is the cause? Yes, Varun, you are right. Drooping eyelid, dystosis. What is the cause of Horner syndrome? Raghu is more related to sympathetic, yes, sympathetic ganglion injury. Yes, you can. Right. So, because if you see now, can anyone tell me why in sympathetic injury we are getting this ptosis? Why we are getting ptosis in a case of sympathetic? Yes, Pancoast tumor can be very well related to sympathetic. We are right. And now this ptosis is because of paralysis of one muscle, that is known as Muller's muscle. There is paralysis of one muscle, that is known as Muller's muscle, and therefore we see. Okay. So this is all sympathetic system. Yeah, Muller's muscle. Yes, right, Chiki. So this is all sympathetic system dysfunction, that is Horner's. Clear? Anyway, so the answer to this MCQ is blowout fracture. Now, use of keratometer. I think everyone can answer this. Keratometer. Yes, curvature of cornea. Absolutely right. Curvature of cornea. Now, what for measuring thickness of cornea? Yes, B is correct answer to that MCQ. What is used to assess the thickness of cornea? Anyone? Instrument, wonderful, wonderful. Tachymeter is used to measure the thickness of cornea. And what about the measurement of corneal cell count? Anyone? Corneal cell count? Yes, Aninda, Chiki, Kushagra, Varun, everyone is right. About corneal cell count. This is specular microscope. So these are some instruments to evaluate cornea, either curvature, thickness, or the corneal cell count. Anyway, keratometer for curvature of. Now, for measuring intraocular pressure, gold standard. Which one is the gold standard for measuring intraocular pressure? Yes, Raghu, you are absolutely right. That is Goldman applanation tonometer. Like usually in, yes, everyone is right. It is B. Usually in routine OPD or otherwise, we use Scheidt's tonometer, which is the commonly used instrument to measure intraocular pressure. But there is always some error because of the concept of scleral rigidity. Right? So there is always some. So that may give a little bit of erroneous reading at times, because if the sclera is thickened, it will show you little higher value. So in that case, your exact intraocular value, pressure value is not shown. It is slightly on the higher side. Now, if we are using Goldman applanation tonometry, then this thing is ruled out, right? Rule out the concept of scleral rigidity, and we get more accurate value for intraocular pressure, and therefore we prefer Goldman applanation tonometers. Everyone right? Now, if pterygium is occurring again and again, what you should do? So, for the prevention of recurrent pterygium, what we can do? Yes, perfect, perfect. We can try MMC. So, chemotherapy with MMC. This is mitomycin C. Yes, and yes, Daniel, Aninda, you are also right. Initially, we should do a conjunctival autograft, and then we should start MMC. So, in one sense, A plus B seems a better answer. But I think if you have to choose between A and B, then B is a better answer than A, because A alone will lead to recurrence again. So, there is possibility of recurrence again with autograph alone. Yes, if we do both together, then that's better. But if they are given as separate entities, then obviously mitomycin C should be given preference over the surgical procedure alone. Clear? So, the ideal answer would have been conjunctival autograph plus mitomycin C. But in case if both the options are different as given in this question, then I think B is slightly better than, because mitomycin C is exclusively used in cases of recurrent cases of pterygium, right? So, based on this concept, I think B is better than A, although A can be right. We won't say that A is absolutely out of the context. It is not so. A plus B is the ideal management for managing recurrent. A is also okay, but B is better than A. But ideal answer should be A plus B. Is learn it like that. So I think question actually needs some correction or correct framing. So here you can see there is this pterygium, which is, no, pterygium is pathology of which structure? Idea? Pterygium is degeneration of which structure? Conjunctiva. Wonderful, wonderful, Kushagra. So this is conjunctiva. And yes, on the advancing edge, Raghu, you are absolutely right. We can see a Stocker's line on the advancing. On the advancing end, we can see a Stocker's. Perfect, perfect. So this is pterygium. If we discuss pterygium, there is one pterygium of nails. Which skin disorder is related to pterygium of nails? Any idea? In dermatology, we can see, wonderful, this is lichen planus. Very good. So, the moment you find the word pterygium of nails, think of lichen planus. Yes, wonderful, wonderful. Everyone is right. Lichen planus. Anyway, coming back to ophthalmology. Now, a person has gritty sensations in both the eyes. Schirmer test shows 5 millimeter recording in both the eyes after 5 minutes. What will you do in this case? Very good, Pratik. Bhuvna, very good. Nilesh, you need a bit of correction. Now, firstly, we need to make the diagnosis. Gritty sensation means foreign body sensations are there. And then Schirmer test is showing 5 millimeter. Normal value for Schirmer test at the end of, what is the normal value for Schirmer test at the end of 5 minutes? It should be around? Anyone? Normal value for Schirmer test? Very good, Kushagra. Yes, so it should be 10 millimeter. Now here in the given case, we are seeing that it is only 5 millimeter. Right? So what we need to do, if we put both these facts together, we will get a diagnosis of dry eyes. Very good, all of you are correct in this regard. So foreign body sensations suggest that there is dryness of eyes, which is verified by the Schirmer test, which is showing decreased tear production. So whenever there is dry eye, we need to supplement it by lubricants. Dry eyes gave lubricants, right? So lubricants is the correct answer to this MCQ. Now, polymorphic neutrophilic infiltration is not seen in. Any idea? Neutrophilic infiltration. When we use the word neutrophils, we are actually considering something bacterial, some entity which is bacterial in nature. So based on that, can you get the answer? Yes, absolutely right. There is no way you can have neutrophilic infiltration in a case of allergic disorder, right? So yes, everyone is right. B. So whenever you find the word neutrophil, always and always think of bacterial entities, right? So neither allergic nor viral, we don't find neutrophilic involvement there. This is as simple as that. Now, a young female was using contact lens since many years, and now she is complaining of having foreign body sensations in the eye. Yes, Pratik, you are right. That is allergic. So yes, long-standing history of contact lens use, it can lead to giant papillary conjunctivitis. So giant papillary conjunctivitis on prolonged contact lens uses. So giant papillary conjunctivitis. Phylactenular conjunctivitis, any idea? Phylactenular conjunctivitis. The term phylactenular conjunctivitis, it is associated with, wonderful, Mycobacterium tuberculosis. So it is associated with Mycobacterium tuberculosis. So we will say that it is a tubercular entity. Please remember phylactenular conjunctivitis for Mycobacterium tuberculosis, although it can also be associated with Staphylococcus aureus. So as such, it is an bacterial entity, but we also associate it with Mycobacterium. Yes. Yeah. A 4-year child with complaints of reddening of eyes, and parents say that this condition recurs mostly in the summers, and on examination there was stringy ropey discharge. Now what could be the diagnosis here? Yes, I think this is a very basic question. The answer is vernal keratoconjunctivitis. Right? So this is, everyone right? This is vernal keratoconjunctivitis, which is also known as spring catarrh, and the name is spring here, right? It is spring here, but this condition is seen in summers, right? It is seen in summer season or hot season. And what we see, what are the clinical presentation, what we find? Yes, Horner Trenta spots, very good. Clinical features, child usually or the patient usually have itching, okay, associated with reddening or photophobia. Okay? So itching is very important here, right? And yes, on examination, what we will see? On examination, ropey discharge. Yes, it's already mentioned, ropey discharge. Apart from that, we will see Horner Trenta spots, which are, what is the location of Horner Trenta spots? Any idea? What is the location of Horner-Trantas spots? They are present at limbus. Very good. They are present at limbus, and limbus is actually the corneoscleral junction. They are present at limbus. Yes, perfect. And then what we will find in palpebral conjunctiva. This is at limbus. Palpebral conjunctiva will show you what it will show. Cobblestoning. Very good. Very good. It will show cobblestoning of conjunctiva. Very good. So please remember this much. And the clinical term is Maxwell-Lyon. So this is Maxwell-Lyon sign for trophy. Very good. So this is in short about vernal keratoconjunctivitis, which is also known as spring catarrh. Now, dendritic ulcers. Any idea where we see dendritic ulcers? Any idea? Yes, yes, absolutely fine. All of you are correct. So this is herpes simplex keratitis, and if you look at the picture, it is very easy to identify dendritic ulcers of herpes simplex keratitis. Okay, this is herpes simplex. Very good. So dendritic ulcers. Now, herpes simplex involvement of eye, what you will not see. What you will not see in the case of herpes simplex eye involvement. Perfect, perfect, Raghu, perfect. You won't see purulent discharge because, yes, Nilesh. Very good, Pratik. Purulent discharge is not seen because whenever you find this word purulent discharge, you are mostly talking about bacterial infection, right? So, herpes simplex being a viral entity, it will not show you purulent discharge. Clear? So, herpes simplex has nothing to do with purulent. Yes, very good. Perfect. Now, a young female had an injury to the eye with a leaf, vegetable matter, and now she is having pain in the eye with photophobia, and we can see hypopyon with satellite lesions. This is very classical. Very good, very good. Perfect. So photo means light, phobia is fear, and this is vegetable matter. So a very classical presentation of a case of fungal keratitis, and the classical and the most important clue in making the diagnosis is satellite lesions. Now, satellite lesions means there is one main lesion and surrounding that there are small lesions, just like a planet has the satellites revolving around it. So similarly, main lesions and small peripheral accompanying lesions, which are known as the satellite. So yes, very good. So vegetative, yes, vegetative matter, that is leaf or plant matter, you can say, right? Classical case of fungal keratitis. Yes, young male with defective vision and irregular astigmatism, which is not corrected with glasses. What can be the answer? Raghu, yes, you are absolutely right. You are absolutely right. This is keratoconus, right? So we have already discussed what keratoconus is. in keratoconus. Yes, what points you can write about keratoconus? There is conical projection of cornea and the curvature of lens is increased. Not lens, cornea. This is cornea, okay? Not because the word keratocornea. No problem. And what will happen here because of the change in the curvature? So there will be irregular astigmatism. Very good, very good. There is irregular astigmatism. Then, importantly, if you tell the patient to look down, what will happen? Astigmatism. Yes, Chiki, you are right. This is Munson sign. What is Munson sign? Let's try it's okay. If you suppose if there is conical projection and if you tell the patient to look downward, so what will happen? The lower eyelid will get indentation. So there is a V-shaped indentation of the lower eyelid the moment the patient tries to look downward. So on downward gaze, there is V-shaped indentation of lower. So this is in short about, yes, Pratik, you are absolutely right, V-shaped lower eyelid. We can also see fissure rings and all, but this is the core summary for keratoconus. So please remember this one. So this is keratoconus. So if I ask you which is not a feature of keratoconus, your answer would be very good. Kaeser fissure rings are not. It is only the fissure rings which are seen. Now, whenever you find the word Kaeser fissure rings, obviously your answer has to be you find this particular word, your answer has to be where we find KF rings or yes, Aninda, you are right. Kaeser fissure rings. Where we find Kaeser fissure rings? Wilson. Very good. It is seen in Wilson disease. Is also known as patolenticular degeneration. So these are rings in the Descemet membranes. Yes, yes, Linda, you are right. ATP7B gene. Yes, are in deposition. So there is deposition in the Descemet's membrane of the cornea. I think you are right. Right. So this is Kaeser fissure ring. It has nothing to do with keratoconus. In keratoconus, we can find fissure rings. Right. We can find fissure. Don't mix up with fissure rings of keratoconus with Kaeser fissure rings of Wilson disease. Yes, and in the Descemet's membrane, this is in Descemet's membrane of cornea. Yes, perfect. Yes, Raghu, you are absolutely right. Fissure rings in keratoconus are in deposition, and Stocker's line in pterygium in the advancing edge. So, next question: perforating injury, which can lead to sympathetic ophthalmitis, involves ciliary body. So always and always, please remember it is perforating or penetrating injury. So it is perforating or penetrating injury, and therefore we call it the dangerous area. Clear? Sympathetic ophthalmitis. Yes, everyone is correct. Caffeine, Chiki, Aninda, Pratik, Amir, everyone is right. Perfect. Now, this is a good question. Which of the drug is useful in acute uveitis? Yes, with this question. Yes, Raghu, you are right. Wonderful, wonderful. Yes, all of you are correct. So in acute uveitis, we should give atropine and also we should give steroids. But atropine is very valuable for two reasons. Number one, it will cause mydriasis, okay? And this mydriasis will relieve the pain, okay? And also this mydriasis will break synecdoche if they are newly formed. Now this is very important. If they are newly formed, then only it can break. If they are little old or if they are consolidated, this is of no help. Right? Of course, so pain relief and breaking of synecdoche. Now what is the site of these synecdoche formation? The synecdoche forms between which structures? Yes, anyone? Okay, we are discussing the synecdoche formation, but this synecdoche or adhesion formation occurs between which structures of the eye? Posterior side of what? Posterior side of which structures? Very good. So suppose if this is the lens, suppose this is the lens, and in the front of lens we know that there is iris. Then here we have ciliary body. So what happens? The adhesion formation occurs in anterior part of lens and the posterior part of iris. So posterior part iris, anterior. Right? So this is the point of formation of the synecdoche, and therefore what we do if we give mydriatic, they will dilate the pupil. It means the iris will move like this, and whatever synecdoche has been formed will break. So that is the principle behind giving atropine in a case of acute uveitis, and it has to be supplemented by steroids, which is anti-inflammatory. It also helps, but yes, atropine is very valuable. The moxifloxacin is antibiotic. That won't serve the purpose. Here we are addressing two important problems: pain and this synecdoche is very problematic. If it is not addressed properly and timely, later on it is beyond management. So synecdoche has to be broken in the early phase only. So this is very important. Please remember atropine for acute anterior uveitis. Now next question: depth of anterior chamber is reduced in. Depth of anterior chamber is reduced in. Yes, Raghu, you are absolutely right. This is angle closure glaucoma. Now, I think all of you must be knowing what is glaucoma. Glaucoma is raised intraocular tension, and we have two types. Very good, Raghu. So we have two types: open angle and closed angle, or what we say angle. Now, what happens in open angle? Now, firstly, you have to understand what actually the word angle is here, right? If you see, if this is iris, suppose this is iris, then here we have cornea, and here we have the drainage channels, that is the Schlenz canal, or right. So this is iris, this is cornea, and these are the trabecular meshwork which is important in draining the aqueous humor, right? So what happens in open angle glaucoma? There is pathology in trabecular meshwork, right? So this drainage channel is at fault. The anterior chamber or the angle of anterior chamber, it is okay. It's just that the trabecular meshwork is at fault. But what is the pathology in closed angle? In here, the trabecular meshwork is okay, but it is just that the cornea is so close to the, so close to the iris, and this angle is so narrow that the aqueous humor doesn't get space to reach up to the trabecular meshwork. So what you write here, decrease depth of anterior chamber, so the aqueous could not reach up to the trabecular meshwork, right? So depth of AC is reduced in angle closure glaucoma. Is that clear? And since the cornea is in so close proximity to the iris, there is the outflow tract of the aqueous is almost blocked. So what we need to do here, we can do iridotomy, and in older times we used to do peripheral iridectomy, used to remove a triangular portion of iris so as to create a bypass for the humor. So we have to create a channel so that the aqueous humor reaches up to the trabecular meshwork. This is the basic. Yes, Shubham, you are right. Outflow of aqueous humor is obstructed, and therefore, since there is no drainage, intraocular tension rises. Very good. So please remember this one for angle closure. Now coming to microaneurysm, where you find them? Yes, Raghu, you are right. Laser iridotomy is done. Yes, so this is diabetic retinopathy, and it is one of the earliest feature of diabetic retinopathy. Clear? Microaneurysm. Now, a known case of diabetes presents with painless visual loss, and when we examined the fundus, we saw blood and thunder fundus. Blood and thunder fundus. Any idea what is this? Very good, very good. So this is CRVO. This is CRVO. We will see all red and yellow. That is blood and thunder fundus, very suggestive of CRVO. Yes, tomato splash is also okay. Yes, everyone is right. CRVO. Please remember blood and thunder flash. Or next question. A child was brought with decreased vision. On examination, we can see a white pupillary reflex and a cauliflower-like mass with calcification growing out from the retina. So the description is quite suggestive of I think there shouldn't be so much of confusion for this question because it's a very basic question, and what is very specific for the answer is white pupillary reflex, right? So white pupillary reflex, which is also known as amaurotic cat's eye reflex, and here when we do fundus examination, usually we have all that red glow kind of impression, but because of this tumor, that area will remain white. So that is known as white pupillary reflex or amaurotic cat's eye reflex, and this is one classical finding. The moment you you find this word, the answer has to be retino. Please don't. Yes, it is also known as leukocoria. Yeah. Leukocoria, perfect. So please don't err on this. Quite forward question. And in a child, so if you write like most common intraocular tumor in a child, answer has to be retinoblastoma. Rhabdomyosarcoma can present with cauliflower-like mass, but white pupillary eye reflex is very indicative of retinoblastoma. So this is retinoblastoma, cauliflower-like mass, and giving rise to amaurotic cat's eye reflex or leukocoria. Right? So this is retinoblastoma, and here you need to just remember few things more, like what we will see on histopathology. What will we'll see on histopathology? Any idea? Any idea what we'll see on histopathology of retinoblastoma? Wonderful, wonderful. So we will see rosettes, and it can be, Winter's Steiner or Homerite. Right? So we will see Flexner, Winter's Steiner. Yes. So Homerite rosettes. Rosettes or sometimes pseudo rosettes have anything. So please remember these words on histopathology. And whenever you are doing treatment, always explore the optic nerve for any chances of tumor invasion. So do explore optic nerve. So retinoblastoma is one of the important tumors. Please read about it. Right? And the classical and the most important clue is leukocoria. The moment you find this word, white pupillary reflex, leukocoria, amaurotic cat's eye reflex, no need to go here and there. Blastoma. Okay. Chalo. Then last question for this session. A person has inability to look downward and laterally. Which nerve is gone? Now, suppose if this is eyeball, patient is unable to look downward and laterally. Now, there are two terms and both have to be included in your answer. Now, before that, we can clearly rule out trigeminal. It has nothing to do with muscles or movements of the eyeball. So you can rule out option D. Now, we will take the options one by one. Now, many students are saying Vishal, yes, you are saying LR6. Okay. So, oculomotor nerve, it supplies, okay, SO4, perfect, LR6, and rest. Now, here we have to include two movements. You are absolutely right, Aninda, you are absolutely right. Actually, which muscle we are talking here? Because there is one muscle which have both these actions, downward, lateral. Which muscle is this? To get to know the muscle, you will get your answer. So which muscle we are talking about? Anyone? Muscle? Wonderful, wonderful, Raghu. This is superior oblique muscle. Yes, this muscle is actually superior oblique. And what are the actions of superior oblique? You know, one of the action is abduction, right? This is the abduction. Then another is depression. You can see this is depression. And third is intorsion. So these are the three functions of superior oblique. So obviously in the question we are given two of the functions which are gone. So based on that, we can presume that this question is actually discussing superior oblique muscle. And since we know that superior oblique is supplied by trochlear nerve, so the answer would come out to be trochlear nerve. So here we cannot take the two options in isolation. They both have to be considered together. If there would have been only, say, downward gaze, then we could have gone for SO, or we could have gone for inferior rectus. Or if there is only about lateral movement, then we could have gone for SO plus LR. But here we have to include both the facts, downward gaze and lateral gaze. This is better explained by the paralysis of superior oblique muscle, which is supplied by fourth trochlear nerve. So I hope you must have enjoyed the session. We can have a little break and then we will continue with the last chapter for today. And again, it is surgery, so it is going to be a little time taking. So please recharge yourself to the side of the. Thank you. Welcome back, dear students. So in this session, we will take MCQs of surgery. So starting with the very first MCQ, a young male, a smoker, having pain in the legs on walking hardly for 200 meters, and then he has to sit down. Previously, he could used to manage to walk to 400 steps before taking the rest, or the 400 steps before the pain comes. Now, what could be the most probable cause? So here, yes, very good, Raghu. So what actually we are, the description is actually what? You look at, of course, there is young male smoker, right? These 2 points are, the answer is perfect. Yes, it is Buerger's disease. Now, what is this symptomatology which we are discussing here? Initially, he used to walk 400 steps, then there comes the pain, and person has to sit. Wonderful, wonderful. Yes. Now, what has happened? Only 200 steps, pain comes, and person has to sit. So this actually is intermittent claudication. So this is defined as intermittent claudication, when here the pain is aggravated on activity and relieved after taking rest. Right? So this is the usual presentation. There is pain which comes with activity, and once the patient takes rest, pain goes away. So this is known as intermittent claudication, and this is in a young male who is smoker. This is classically indicating towards Buerger's disease, which is also known as thromboangiitis obliterans. Clear? So this is the typical intermittent claudication of Buerger's disease. And yes, if this continues, then there would be a time when the person will go into rest pain. It means whether he is doing activity or whether he is doing rest, he will have pain all the time, and then we need to go for surgical procedure. So what we need to do in cases of rest pain, in cases of Buerger's disease? Any idea? What we need to do? Any idea? In cases of rest pain, the pain is 24 hours. Anyone? Okay, that is, yes, we have to tell the patient, please stop smoking. That is, of course, thing. But for the pain which is there, which is present there for 24 hours, what surgery? Any idea? What surgery can we do? Very good, Chiki. We need to do lumbar sympathectomy. Very good. But in a male, if you are going for lumbar sympathectomy, you have to spare which segment? Very good. You have to leave L1. Why we need to leave L1? Very good. Yes. Ninda, Raghu. Why we need to spare L1? Otherwise, there would be, yes, in a male, yes, there might be ejaculatory dysfunction. It is very important to spare L1. Don't cut L1, otherwise you'll have reproductive problems. So this is in short about Buerger's disease, which is also known as thromboangiitis obliterans. The classical presentation in initial stages is that of intermittent claudication, which can proceed to become rest pain. If there is development of gangrene, definitely we need to go for amputation as well of the affected part, right? So in short, and of course, patient has to quit smoking. Now, next question, not a feature of burn. Yes, anyone? What will not be seen in one? Yes, Shubham, you are absolutely right. There is hypoproteinemia. There is hypoproteinemia in cases of, so the answer is D. And sepsis, shock, we can see, and hypovolemia can affect the kidney as well. So okay, shock in early stages and sepsis in late stages, as the protective covering of the skin is lost, so sepsis is always a possibility there. Yes, hypoproteinemia, the reduction of albumin. Good, Pratik. Now, this is important. A third degree circumferential burn involving the extremities, arm and forearm region. What is the most important thing to consider? Yes, third degree circumferential burns in the over the extremities. Yes, Honeybee, Shubham, perfectly right. We need to look for peripheral pulse and circulation. Yes, arc. Okay. Now, third degree burn. What is this third degree burn? What is this? Any idea? The burn is involving or is reaching up to the bone, and what happens here? The nerves are also burned out, right? So here the nerves are also burned out, and because of this particular thing, what will be the, yes, Shubham, you are right, reaching up to, very good, Raghu, because the nerves are burnt out, so the burn is painless, right? So painless burn. Yes, right. Now we come to the another keyword that is given in the question, that is circumferential. What is this circumferential word? Circumferential means encircling the entire circumference of a limb, right? So encircling the entire circumference of a limb, and what could happen? Yes, absolutely, you are right. So the entire limb is encircled, and what can happen here? Because of this encircling, there might be possibility of development of a constriction band, right? Yes, right, Raghu, eschar can form. So there might be, in simpler terms, there might be formation of a constriction band. It can be eschar or fibrotic tissue, whatever. So there can be a constriction band, and whenever there is a constriction band, it has a tendency to compress arteries, right? So this constriction band can compress the arteries, and this might lead to ischemia or other vascular complications. Yes, absolutely, gangrene if not corrected well in time. So therefore, your first priority in a case of third degree circumferential burn involving upper limb, lower limb, whatever, always make sure that there is no constricting band. Secondly, check the distal pulses. If you can feel the pulses adequately, it means there is no fear for that vascular compromise. So the pulsations need to be checked regularly, right? So always and always have a watch over the distal circulation by palpating the pulses. This is very important here. And even, yes, Pratik, you are right, that will interrupt with the proper circulation. And Aninda, you are right, if you think that there is a scar tissue, better remove it, because that scar tissue has a compressive or constrictive effect over the arterial blood flow. So one has to be very vigilant whenever you see a circumferential burn in a limb. So I think this concept is clear, right? Now, next question. A patient has ulceration on his leg where he had burn around 10 years back. And yes, everyone is right. This is nothing except marginal ulcer. Now here, the word ulcer is quite confusing because this is actually a squamous cell carcinoma, right? So the word ulcer is, yes, so it's actually, yes, everyone is right. Shubham, Mark, Honeybee, everyone is perfectly right in your answers. So marginal ulcer is actually a sort of, squamous cell carcinoma, develops after long time, particularly at the site of burn in a patient, right? So this is squamous cell carcinoma. Now, moving forward to next question, condition which is present at birth and persist throughout life. Yes, so if you look at the options, anyone? Okay, I am getting mixed reactions, but majority of the students are right. So no problem. Those who couldn't make it, I am just going to give you some trick so that you don't mark it wrong later on, right? So the correct answer is port wine stain. Now here it is quite easy to remember, right? You can just remember 3 P's. Just remember 3 P's. So one of the P, of course, is present at birth. Okay. Another P is persist throughout life. And third P is, of course, condition itself. So port wine. So I think if you remember these 3 P's, you will never forget this particular concept and you will never be wrong in your answer later on, right? So remember 3 P's: present at birth, persist throughout life, and the entity is port wine stain. Now this entity has to be differentiated from strawberry angioma. Now this is a classical picture of port wine stain seen in a newborn, and it will persist throughout life. Now this condition has to be differentiated from strawberry angioma, and can again remember 2 things: not present at birth. It is not present at birth, it takes some time to appear, and it will not persist throughout life, right? So it is not going to remain permanently. It might resolve by the age of 7 to 8 regional thrombosis, right? So strawberry angioma is not present at birth and it is not going to persist lifelong. So just remember these 2 conditions: strawberry angioma and port wine stain, right? So this way you will never be wrong in your, yes, Raghu, you are right. As the baby will grow, it will regress, and maybe after 7 to 8 years, it won't persist anymore. So please read the statement properly, and this is one question I think you will score, right? There won't be any problem. Now, not a complication of chronic lower limb edema. Yes, not a complication of lower limb edema. Any other answers? See, I think if there is lower limb edema, it has nothing to do with varicose veins. Now, what is varicose veins? Yes, Raghu, Ark, you are right. What is varicose veins? Actually, if you take the example of veins of the lower limb, since they have to, push the blood anti-gravity, right? So they have valves, and the blood flow is like this. So once the blood, this is going anti-gravity, right? So once the blood goes upward, it won't come back again distally because of the presence of these valves. So it is the duty of these valves to push the blood upward and to prevent its downward accumulation. But what happens in varicose veins? These valves are incompetent. So in varicose veins, these valves are incompetent, and as a result of which, what will happen? The blood, it will come back and it will pool in the lower limb veins, right? So there is pooling of the blood in the veins of the lower limb, and if you can see here in this image, you can see the tortuous dilatation of the lower limb veins which are filled with blood, right? You can see the same condition on both the side. So this is a very typical picture of varicose veins, and it has nothing to do with edema of the lower limb which has persisted for a longer duration. So lower limb edema has nothing to do with varicose veins, which is a separate entity. And yes, what are the factors which will promote varicose veins? The conditions which are predisposing. What are the predisposing conditions for varicose veins? Any idea? Very good. So any profession which demands prolonged standing. So it can be, surgeon, it can be bus conductor or teacher, anyone who is standing for, yes, absolutely right, Shubham. So anyone who is standing for long duration of hours, they are predisposed to this condition. It doesn't mean that everyone will develop the condition, but they are prone for varicose veins. So varicose veins has nothing to do with chronic lower limb edema, right? It is just these valves, they don't function properly. Now, most commonly affected vein, any idea? Yeah, obesity is okay. Traffic police, good. Yes, so most commonly affected is great saphenous vein. So this is great saphenous vein. And any idea what investigation would you like to do here? Any idea? Which investigation you would prefer? Wonderful, wonderful. Doppler or duplex USG. So Doppler is good. And there is one clinical test related to, yes, USG, Doppler USG, yes, duplex scan, same thing. So there is one clinical test, and that is known as duplex is fine. Brody Trendelenburg test. Any idea what is this Brody Trendelenburg test for varicose veins? Yes, Honeybee, you're right. Yes, tunicate test, Vishal, perfect. Now, actually, what we do here, we look for competency of saphenofemoral junction. So what we check here, we are checking the competency of saphenofemoral junction. So why I am saying so? Because suppose if this is the femoral vein, suppose if this is the femoral vein, then the great saphenous vein, it goes and it drains into the femoral vein. This is great saphenous vein and this is the femoral vein, and this again, this drainage is also guarded by a valve. So it just makes sure that whatever the blood, venous blood has been drained to femoral vein, it does not come back into the great saphenous vein. So if we wish to check whether this valve is working perfectly or not, we can perform this Brody-Trendelenburg test. And what we actually do here, firstly, we will elevate the affected lower limb, right? And we are doing exsanguination. It means we are pushing all the blood from great saphenous vein into the femoral vein. So when we elevate the lower limb, all the blood from GSV will go into the femoral vein. And then what we will do, we will put a finger, or tunicate also, we can use that, right? So we can put a finger at the valve. Okay. So if you want to do a manual test, we can put the thumb over here, right? And then we will lower the limb, right? Then we will lower the limb, right? And then we will remove the thumb or tunicate, whatever you are using, and we will look at the great saphenous vein. If it fills with blood again, it means this valve is not working at all. Whatever the blood we have manually pushed into the femoral vein, it has came back again into the great saphenous vein. So this is Brody-Trendelenburg test, which actually help us in assessing the condition of the valve at the junction of great saphenous vein with femoral vein. Anyway, this is a clinical test. So varicose veins. Now, next question. A 50-year-old male complained of pain in left thigh and left calf region, and on examination, left femoral and left popliteal arteries were not palpable. So the condition is more affecting the left side. It is more affecting the left side, and the right side is absolutely normal. Right side is normal. It means we can feel this properly. So what could be the site of blockage? Yes, very good. Amir, Chiki, Shubham, Vaibhav, Raghu, Honeybee, all, oh, yes, perfect, perfect. So the answer is iliac artery level. Now, the pulsations which are not felt, the obstruction has to be at a level above those areas. So suppose if I'm saying that femoral artery is not palpable, it means the blockage has to be a level above the femoral artery, and that is usually either it can be at the level of iliac arteries or it can be at the level of aorta. The branches, like suppose this is aorta, it divides into two common iliac arteries, right? And then they go on to divide into external, internal iliac and continuous femoral or popliteal artery. So suppose if I say the obstruction is at the level of aorta, then in that case the condition has to be, it should be manifesting on both the sides, right? But in this particular case, we know that it's only the left side which is affected, the right side is normal. So it means the obstruction is involving only the left iliac artery and the right common iliac artery is absolutely normal. So the obstruction has to be at the level of iliac artery, right? It can't be aortic, because the moment you use the word aorta, it has to be bilateral. Perfect. And since the femoral and popliteal are blocked, so the block has to be proximal to the point of palpation of the femoral and popliteal arteries, right? So the better answer is iliac artery level. I think everyone has marked it right. Great, great. You understood the concept. That's very good. Now, a patient underwent long duration surgery, and then he was bedridden for many days. Now, the doctor elicits a positive Human sign. Yes, I think everyone can answer this. This is a classical picture of DVT, and we have been given two important keywords for predisposing factors. One is, of course, long duration surgery, like replacement surgeries, and second is prolonged bedridden state. So the moment you have these two words, it is quite enough to suspect DVT. But in this particular case, there is an additional confirmatory hint given, that is the positive Human sign. They have given positive Human sign, and therefore these 3 points are quite useful in making the diagnosis of DVT. Now, what is this positive Human sign? Anyone? What is Human sign? What is Human sign? In Human sign, okay, so in positive Human sign, forceful dorsiflexion of the foot causes very severe pain in calf muscles, right? The calf area, right? So that is Human sign. So the moment you have this kind of clinical picture, long duration surgery, prolonged bed rest, and a positive Human sign, the condition is classically DVT. Perfect. So let's move on to next question. CVP is increased in which type of shock? Now, the CVP, it actually reflects the pressure changes of the right side of the heart, and if CVP is raised, we can say that there is right sided heart failure, so cardiogenic shock. So CVP for right sided heart failure, that is cardiogenic shock. Okay. So nothing much to discuss here, because it correlates more with the right side. Clear? Cardiogenic, yes. Next question. A case of chronic hepatitis now is having hematemesis since last 2 days, and this hematemesis is because of variceal bleeding, and despite giving treatment, the patient dies. And what could be the reason for the death of the patient? Yes, this is hypovolemic shock, which is actually because of excess of, right? So this is hypovolemic. So this is hypovolemic shock, and if someone can define what do you mean by the shock, shock is defined as a state of decreased the oxygen supply to the tissue is decreased, that is shock. And especially if there is a lot of bleeding, then it goes in favor of hypovolemic or hemorrhagic shock, right? So the moment you look at the bleeding point, hypovolemic shock. Now this is again a repeat question, so I think we don't need much. So 5th post-operative day, fever, pain in calf muscles and pedal edema. This is nothing except DVT. Now this is good. A female patient is having blood pressure of 90/60, pulse rate is high, 150 beats per minute. After blunt trauma abdomen, how you are going to assess this patient? Now see, we have the algorithm for blunt trauma is we have to check the vitals first, right? In cases of unstable vitals, it means low blood pressure, high heart rate, we need to go for bedside USG, right? What you call fast. No need to shift the patient from one place to another, because you never know, during that shifting process the patient might succumb. So if vitals are stable and if you feel that yes, the patient can be shifted to the CT room, you can send the patient for CT scan. So here BP is on the lower side, heart rate is on the higher side, so it means patient is not stable enough to be sent to the CT scan room, right? So the patient is unstable, so we will prefer doing a bedside USG. Clear? Don't shift the patient because he is unstable, right? So this is the algorithm which guide us what needs to be done in a case of, while we want to evaluate a case of blunt injury abdomen. Now, a case of road traffic accident, he was brought with blunt injury abdomen and there was simultaneous head injury. GC, the Glasgow Coma scale was 9/15 and there was no visible external bleeding. Despite giving IV fluids, patient was still hypotensive. Now, which of the following is not the cause for this hypotensive state? I think it's quite basic. Yes, everyone can mark it right, because the bleeding in the brain it cannot be severe enough to cause hypotension. But yes, the blood which is bleeding inside the, you say, thoracic cavity or within the peritoneal cavity, or if there is injury to a structure, a vascular structure like spleen, this can cause excessive bleeding, right? And all these bleedings, they are concealed. It means they won't be shown outside. So they are concealed bleeding and they can lead to hypotension or hemorrhagic shock. So one has to be very careful while dealing with cases of pneumothorax or rupture of abdominal viscera or retroperitoneal hemorrhage. And obviously subdural hemorrhage can never bleed so much to cause hypotension or hypovolemic shock, right? So this is important here. And also you can remember a couple of fractures. I think it's very important to mention. So one is fracture of pelvis and another is fracture shaft of femur. These are two fractures which have this tendency to cause a lot of hemorrhage, and therefore the one has to be very vigilant while evaluating these injuries, right? There is possibility of severe hemorrhage of the amount of about 1 to 1.5 liter. Yes, Raghu, you are almost. right? So whenever you see this kind of picture, always keep the possibility of hypovolemic shock or hemorrhagic shock, particularly if you think that the BP is still on the lower side despite giving fluid resuscitation. So obviously, brain hemorrhage won't cause hypovolemic shock. Now the next question, there is a patient in whom there is gallstone in the cystic duct and there is dilatation of the common hepatic duct. Now what is this known as? This is Mersey syndrome. Actually, what happens in Mersey syndrome? Suppose this is the common bile duct. We have the gallbladder. Is cystic duct. Sorry. This is the cystic duct. Gallbladder, and then it joins with the common hepatic duct. Okay. Common hepatic duct, which is actually formed by the joining of two, the right and the left hepatic duct. Left hepatic, right hepatic. Sometimes what happens, there is a stone within the cystic duct, and this stone is big enough to encroach upon the lumen of the common hepatic duct, and therefore what we see that there is slight dilatation of the common hepatic, right? So this is known as Mersey syndrome. Yes, Shubham, you are absolutely right. So this is Mersey syndrome, and you can see the picture here. There is the stone within the cystic duct, and this pushes upon the common hepatic duct, resulting in dilatation of the common hepatic. This is Mersey syndrome. Hello, next question. There is a female patient who is having pain in right hypochondriac region, which goes to the back, and this is associated with vomiting, and guarding can be seen in the right hypochondrium, and there is past history of similar episode. Now what could be the probable diagnosis? Okay, now in such questions there are few words which needs to be evaluated. First is right hypochondrium. Of course, another thing is pain which is radiating to back. Yeah, this might confuse you. Then okay, vomiting is not specific, it might confuse you, and there is history of similar episode. Now what is important here, just think of a structure which is lying within the right hypochondrium, then I think it would be more easy for you to reach up to a particular diagnosis. So here for that again you have to recall that concept of the 9 quadrants of the abdomen. If we draw different lines, this one is transpyloric plane through L1, this one is transvercular through L3, L4, then these are 2 vertical mid-clavicular planes. This is also mid-clavicular. Now based on these 4 lines, we can divide the abdomen. Yes, Shubham, your views are perfect, but let me explain it. So based on these 4 lines, we can divide the entire abdomen into 9 segments. This one is right hypochondrium, and this one is left hypochondrium. This one is epigastrium. This one is umbilical. This one is right lumbar. This one is left lumbar. This one is right iliac fossa. This one is left iliac fossa, and this one is hypogastrium. Now the question is discussing about the right hypochondrium. So specifically it is saying that right hypochondriac region. Now you have to think of the structures which are present in the right hypochondrium. And I think all of you must agree that there's two structures mainly here. One is liver and another is gall bladder, right? For pancreas, we usually take the epigastric region, right? So the moment the word is about right hypochondrium, you have to choose your answer either from liver pathology or from gallbladder pathology, right? So despite having these confusing words like the pain which is going to the back with vomiting, still you need to go for acute arthritis because of this right hypochondrium word. And yes, this is very classical presentation of acute pancreatitis, that there is severe epigastric pain and the pain is radiated to the back along with vomiting. But we cannot ignore this particular hint given in the question. So based on that, I think it's better we mark it acute. Please remember acute cholecystitis. Now, next question. 6-year-old child with multiple episodes of hematemesis and vitals stable, it means blood pressure all normal, but spleen is enlarged. Now, mother tells that he had jaundice and he was given exchange transfusion procedure after birth in the same hospital. Now, what the most likely diagnosis? The answer? Now, this is okay, a little difficult for all of you, but I would like to explain this. Now, if you look here, this is a classical picture of something like what we see in cases of adults, that is variceal bleeding, right? So there is variceal bleeding. You can see there is hematemesis. So there is hematemesis, that is there is vomiting of blood, right? There is splenomegaly. Clear? So these 2 points are features of variceal bleed. Okay. Now, in a child with normal vitals, it goes in favor of portal vein thrombosis. In a child, you have to make a diagnosis of portal vein thrombosis. This is for child. Now, if the same presentation is seen in adult, usually we see there is deranged vitals. So vitals are disturbed, right? Signs of hypotension, and this goes in favor of portal hypertension. Here, secondary to cirrhosis. To see the basic, the presentation is somewhat similar, but in different age group, the diagnosis becomes entirely different, right? So that's why I particularly kept this question. If you see a child with variceal bleeding, think of portal vein thrombosis. In an adult, you will say it is hypertension, right? So this is in a child, you have to go, this is a case of child, vital stable, features of variceal bleed, think of portal thrombosis. Please don't mix up, just make sure that what is the age group in question, and based on that you can answer the, right? Now, next question. A lady has a lump in her upper abdomen for 2 months. So this is 8 weeks, you can say, and is slightly increasing in size. She is complaining of early satiety. Okay, this is one part of the question. Now, there is a past history, and as per the past history, she is saying that she was having acute severe pain in the upper abdomen, for which she was admitted for nearly 10 days, and this episode occurred 3 months back. Now, the third part of the question is that on examination, The mass was firm, smooth surfaced, and not moving with respiration. So what could be the diagnosis? So firstly, we can assume that probably whatever the condition she is having now, it might have something to do with the episode for which she needed hospitalization. So what this episode can be: acute, severe, upper abdominal pain, right? Any idea? Yes, Raghu, you're absolutely fine. This can be a case of acute pancreatitis. Now, based on these particular words, we cannot make a clear-cut diagnosis of acute pancreatitis. We are addressing the current situation as well. There is a lump and it is of 8 weeks duration, and that is leading to early satiety. It means it is compressing over the stomach. So that what is leading to early satiety. So that is actually a pressure effect. Now, so whatever the condition she is having right now, it means it is a complication of the episode of acute pancreatitis. And in around 8 weeks, the complication of pancreatitis which might come is, yes, absolutely fine, it is pseudocyst of pancreas. Right? So this is complication is pseudocyst pancreas, and yes, it is a so it is a complication of acute pancreatitis. And why we call it pseudocyst? Because there is no true lining of this cyst. It is just simply a collection of fluid which later has a membranous lining. So it is known as pseudocyst of pancreas, and yes, it can increase with time. So if you do, we can have a CT scan and we can see swelling in the vicinity of the pancreas. So this is pseudocyst of pancreas, which can be a complication of acute pancreatitis in adults. In children, it can be seen after abdominal injury. So in cases of children, it is not necessary that there might be a previous episode of pancreatitis. It can occur because of even a history of trauma, right? But in adults, yes, it is always a complication of acute pancreatitis. And if the size is more than 6 centimeter, or if the duration is more than 6 weeks, obviously we have to resort to the surgical management of this condition. Otherwise, it is presumed that it might resolve, but it is the rule of 6 says that if it is more than 6 centimeter, or if it is 6 weeks or older, then we have to go for surgical drainage, right? So treatment point, we can go for drainage, and what we prefer here is internal drainage, and this is into the stomach, right? So we can create a portal so that the content of the cyst drains into the stomach. So this is known as internal drainage. Although we can try external drainage, but internal drainage is also preferred procedure for pseudocyst of pancreas, and this is one those rare entities where we prefer internal drainage. So just remember internal drainage for pseudocyst of pancreas. Okay, so this is the explanation to this MCQ. Next MCQ: a patient has recurrent abdominal pain. Okay? So there is recurrent abdominal pain, then gallstones and jaundice. There is reticulocytosis and hyperbilirubinemia. What is the clinical diagnosis? Now, here there are few words which you need to understand first, and then I think you will never be wrong in your diagnosis. One of the clue which is given to you is gallstones, and if you know the types of gallstones, principally we have two types of gallstones. One is cholesterol, and the second is pigmented, and the third one is of course the mixed. So cholesterol, as the name suggests, it has something with the cholesterol, but these pigmented gallstones, it has derived its name and because it is seen in hemolytic conditions. It is seen in hemolytic conditions, and therefore you will see that there is excess of bilirubin, is actually jaundice in this patient, right? So here we can see jaundice and we can see hyperbilirubinemia, that what is explained on the basis of hemolysis. Now, whenever there is hemolysis, body will try to compensate for the, now hemolysis means there is RBC destruction. So it means the body will try to make up the loss by producing more of RBC, right? And these more of RBCs are actually the immature RBCs, which we call as reticulocytes. So whatever this reticulocytosis can be explained based on this particular phenomena of hemolysis, that body is trying to produce more and more RBCs, which are actually the immature forms. And I think most of you must be knowing what RBCs, reticulocytes are. They are RBC plus nucleus. Clear? And if the nucleus is gone, they become RBC, right? So this all picture is related to hemolytic episode, and out of all the options, the best option which represent hemolytic state is hereditary spherocytosis. Okay, so recurrent gallstones, abdominal pain, jaundice, reticulocytosis, raised bilirubin levels, this is all somewhat related to hemolysis. And in hereditary spherocytosis, just take few words about hereditary spherocytosis also. So here this is actually an autosomal dominant condition, right? And here what happens, the RBCs, they assume spherical shape, the spherical RBCs. Normally RBCs are biconcave disc, okay? But here they become spherical, and these spherical, they lack flexibility. So as they try to pass through the sinusoids, they cannot alter their shape, and these sinusoids of spleen, and since they can't alter their shape, so they are destroyed. This is actually hemolysis, right? This is the basic pathology of hemolysis in a case of hereditary spherocytosis. And I think all of you must agree that if we want to treat this condition, we cannot do anything related to the shape of RBCs. What we can do, we can remove the source of that hemolysis, and that is nothing except the spleen. So treatment wise, what we need to do, we have to remove the spleen. This procedure is known as splenectomy, right? But whenever you are removing spleen, there is possibility of overwhelming post splenectomy infections, which is actually very violent pneumococcal infections. So always and always give vaccination before doing splenectomy, right? So this is in short about hereditary spherocytosis. Okay, so this is how we can just summarize up the entire thing in relation to this MCQ, right? So we can move on to next question. And parasite related to development of gallbladder carcinoma, especially after consumption of raw fish. I think most of you must, yeah, yes, Clonorchis sinensis. No much discussion in this question. Now again, we have a question in which elderly male presents with painless, right, progressive jaundice of 2 months duration, okay, and there is a history of weight loss. Patient is having loss of weight, and when you palpated, you could easily see that the gallbladder was palpable, which is smooth, non-tender and globular. Bilirubin levels are high. Now, how we can frame all these points into a single diagnosis? Now here, see what is happening. There is jaundice, right? Increased bilirubin, and this is reflected in the serum bilirubin level, because normally it should be around 1. So it is high. There is weight loss, and whenever you find this term weight loss, always think of malignancies. So weight loss in an elderly person should not be ignored. It has to be related with some tumor somewhere. Now here, what point is going to help us is the finding of gallbladder. We can palpate the gallbladder, right? So we can palpate the gallbladder. It means there is no problem, there is no pathology in the gallbladder, right? Because what happens, this kind of presentation can be seen in carcinoma of gallbladder also, but this kind of presentation can be seen in carcinoma gallbladder, and we know that one of the predisposing factor for carcinoma gallbladder is gallstones, which can lead to cholecystitis. Fine, it can lead to cholecystitis, and the important thing is that because repetitive episodes of inflammation, the gallbladder is fibrotic and shortened, right? So in such a case, it will be never palpable, right? So if you are seeing a case of gallbladder carcinoma with jaundice, and if you are able to palpate the gallbladder, then obviously your provisional diagnosis is wrong. In a case of carcinoma gallbladder, you will never be able to palpate the gallbladder because of repetitive episodes of inflammation. It would have already been shrunken and it shouldn't be palpable, right? So this is what the Courvoisier's law tells us. So if you are dealing with the case of jaundice, it can be, in terms of tumors, it can be either because of carcinoma gallbladder, or it can be the periampullary carcinoma, which most of you have answered right. So this is periampullary carcinoma, that is carcinoma of head of pancreas. Now for this, you need to understand what actually the term periampullary carcinoma is. Suppose this is the second part of duodenum here, then you all know that this is the common bile duct which is coming from above, and it joins with the major pancreatic duct, right? So this is the major pancreatic duct. This is the common bile duct, and this opens at the second part of duodenum at the ampulla of Vater, right? Major duodenal papilla, you say ampulla of Vater. So there might be the possibility that tumor is somewhere in this region, and then, right, so the tumor is somewhere in this region and it is interrupting with the drainage of the bile, right? So in this case also there would be increase in bilirubin content of the body, right? So in a tumor with jaundice, you have to palpate the gallbladder, and that what will differentiate whether this jaundice with tumor is tumor of gallbladder or it is periampullary carcinoma, right? So periampullary means it is related to ampulla of Vater, and it can include carcinoma head of pancreas, or it can also include carcinoma second part of, right? So this is a very beautiful concept, and here Courvoisier's law help us in reaching up to a provisional diagnosis whether the given case of a tumor with jaundice is a case of periampullary carcinoma or it is because of gallbladder carcinoma. If the gallbladder can be palpated, never think of gallbladder carcinoma, because the usual pathology of cholecystitis is going to make it shrink and we cannot never palpate it, right? So this is Courvoisier's law, And if you can palpate gallbladder, straight away you can go mark the answer as periampullary carcinoma or carcinoma head of pancreas. Right? So this is very important here. So this is what Courvoisier's law help us. Now, next question, investigation of choice for dysphagia. I think most of you can answer. Investigation of choice for dysphagia. I think all of you must be knowing the definition of dysphagia, that is difficult swallowing. And whenever we are taking this particular topic, we usually take 2-3 conditions only with respect to the exam. One is, of course, dysplasia cardia. Second is carcinoma esophagus. And third, at times we can take Denker's diverticulum. These are the 3 important conditions every student should know. Now, coming back to the question, what is the investigation of choice for dysphagia? How you will evaluate a patient who is coming to you with dysphagia? Now, the word is investigation of choice. Please mind this word. It means the one which is the best amongst all. And to answer this, I think it's better you think of a case of carcinoma esophagus. And if you want to investigate this case in a better manner, I think all of you must agree that for any tumor anywhere, what is the best investigation? That is biopsy. So that is the best investigation, any tumor anywhere. Now, if you want to evaluate a case of carcinoma esophagus with biopsy, then obviously you have to do what you need to do first? Endoscopy. Very good, Shubham. So you need to do endoscopy. So that way, I'm just correlating the things so that you can understand that investigation of choice for dysphagia is endoscopy. Right? I just gave this example so that you can correlate. We can pass a tube and we can see the interior of the esophagus or gastroesophageal junction. That is very important. So this is investigation of choice. Yes, if somebody asks you initial investigation, then yes, I'll agree, you can go for barium swallow. But if you want to make a perfect diagnosis in one shot, go for endoscopy. Now, which vitamin deficiency is seen in short bowel? Now, short bowel syndrome means there is a resection of portion of the intestine, and we know that terminal ileum is the point of absorption of vitamin B12. So if we do any resection, there is malabsorption of vitamin B12. Now, this is a male newborn, and he had presented with abdominal distension and no passage of fecal matter since last 48 hours. Since last 2 days, there is no passage of fecal matter. Now here, the question is about the next best. It's not about the investigation of choice or the gold standard investigation. It is like, what next will you do? So, yes, anyone? Yes, perfectly fine, perfectly fine. Initially we will go for barium enema, because what is the clinical diagnosis for this case? What is the clinical diagnosis for this case? Anyone? Male patient, abdominal distension, and hadn't passed fecal matter since 2 days. What you should do? What is the clinical condition actually? Very good, Raghu. This is Hirschsprung's disease, and initially we can go for barium contrast enema, right? And if they ask you about the investigation of choice, then of course it is rectal biopsy. Rectal biopsy is the investigation of choice. Clear? Now, what you will see in rectal biopsy? There will be absent rectal biopsy. We will see absent ganglion cells of the urbic or myenteric plexus, right? So this is the investigation of choice, but if they are asked about the initial, go for barium enema, and this is what you will see on barium enema. So we can see a ganglionic segment which is narrow, and this is proximal dilated segment, and in the aganglionic segment we can see serrations or tooth appearance, serrations like this. This is Hirschsprung disease or congenital aganglionosis. Very good. So start with barium enema, and if you want to go for the perfect investigation for diagnosis, then rectal biopsy is best, full thickness rectal biopsy. The next question, a newborn is presented with herniation of bowel and liver through the umbilicus, and this is covered by a sac or a membrane. What is this? Very good. This is omphalocele, and the condition with which omphalocele has to be differentiated is gastroschisis. Now, in omphalocele, if you see, there is a sac. So there is a sac like this, okay? And here there is an attachment of umbilical cord. This is the attachment of umbilical cord, and here you can see the intestine. All intestine or even liver can come out. So this is a sac, right? So this is omphalocele. But what you will find in a case of gastroschisis, which is almost a similar kind of entity. So here you will see that there is a sac, not a well formed sac, with herniated content, right? There is herniated content, but the umbilical cord will be by the side. Umbilical cord is something like, so this is umbilical cord. So here we can see that the umbilical cord is right on the attached to the sac, right on the top, but here the umbilical cord is lying sideways. In both the conditions there will be herniation of the bowel, but it is just the attachment of the umbilical cord which help us in differentiating the two, right? So in omphalocele we can see that the sac, and on the top of that we can see the attachment of umbilical cord. So this is omphalocele. In gastroschisis it lies to one side. Yeah. So this is one thing. Then exhaustrophy of bladder, the anterior abdominal wall is absent, so the interior of the urinary bladder can be seen through the anterior abdominal wall. So that is exhaustrophy of the bladder. Right. So next question, a newborn with regurgitation of all feeds and coughing and cyanosis with feeding, most likely condition. So here there is regurgitation and some respiratory problems as well. What can be? Yes, there is coughing, cyanosis, regurgitation, and this is nothing except brachioesophageal fistula. Okay? So this is brachioesophageal fistula, and what happens here? There is closure of the esophagus. Esophagus is atretic, right? So it is blocked, and it is communicating with the respiratory tract, with the trachea. So whenever child is taking any feeds, other than going into the stomach, it is going into the respiratory tract, and that what is leading to cough. So the respiratory symptoms are based on this particular pathology, and there is possibility that whatever the feeds he is taking, it might come out through the mouth. So regurgitation and coughing, answer has to be tracheoesophageal fistula. Then a lady in her 20s presents with pain, abdomen, distension, and vomiting, and we saw that she is having alopecia and crepitus in the abdomen. Any idea what can be the condition? Now, this is a psychiatric condition, and yes, it is trichobezoar. Tricho means hair. So the psychiatric patient is plucking her hair and she is eating them. That's why she is having alopecia, and this abdominal mass is resulting in abdominal pain. So this is trichobezoar, and there is one more entity that is known as phytobezoar. The word phyto means plant or vegetable. Yes, very good. The psychiatric condition is trichotillomania. Pulling out the hairs. So this is trichobezoar. Right? You can see this is how, when it is removed from the gut, you can see the exact appearance as that of the gut. This is trichobezoar. I think we can take a 10 minutes break, then take the remaining question. Thank you. Just 15 minutes break. Okay, dear students, we can continue, and hopefully we will finish surgery in this round. So the next question is about a kind of malignancy which can be expected in a case of Barrett's esophagus. Right? So the normal epithelium of esophagus is, yes, all of you are right. So the normal epithelium of esophagus is stratified squamous non-keratinized. So this is the normal usual epithelium. But what happens because of prolonged gastroesophageal reflux disease? There is metaplesia, and this stratified squamous non-keratinized get converted into columnar variety. So it gets converted into the columnar variety. Yes, it's squamous to columnar metaplesia. And since the tumor which will develop depends on the kind of epithelium, so here, if there is any tumor, that is going to be adenocarcinoma. In a normal esophagus, it is always going to be a squamous cell. So in a case of Barrett's esophagus, we will find adenocarcinoma just because of the fact that the epithelium has changed from the stratified squamous keratinized to columnar variety. A 60 years old male patient presented with bleeding per rectum, and he was having second degree hemorrhoids. What should be done best? Now, the second degree hemorrhoids are the one which prolapse. These prolapses on exertion or the bearing down effects, but they reduce spontaneously. So this is second degree hemorrhoids or second degree piles. Now what we can do in this case, yes, very good, we can do banding. So what we actually do, so suppose if this is a hemorrhoid, we can put a band at the neck, and this band will reduce the amount of blood flow, and over a period of time it will shed off. So it's just we are just cutting the vascular supply to this portion. So over a period of time this will shed off. So this is known as banding and very valuable for second degree prolapse. Then the internal opening in a case of fistula in ano is starting from, any idea? So now firstly, what is this word fistula in ano? What happens here, because this is anal canal, is surrounding skin. So there is a fistulous communication like this. So there is a fistulous communication which is connecting from inside of the anal canal, and it is opening on the perianal skin, right? So this is fistula in ano, and since it is connecting with the anal canal, so the patient usually have a serous discharge commonly. So there is usually a serous discharge, which is the commonest clinical presentation. Now, in a case of fistula in ano, the usual presentation or the usual site of this internal opening is at the dentate line. So it is at the dentate. Here, this is somewhere, this is the area of, right? So the internal opening is at the dentate line. No, this is not painful. Fistula in ano is not painful, right? So it is inner, on the inner side, it is connecting to the anal canal at the level of dentate line. And to have an idea about the track of this fistulous communication, we are following one rule that is known as Goodsall's rule. So suppose if the patient is lying in front of you, and suppose this is the right side of the patient, this is the left side, and you are just facing the patient. So considering the anal opening, we draw a transverse line, and as per the Goodsall's rules, if there is any fistulous opening in front of this line, the course is always straight. Okay? So the course of the fistulous tract is always straight if the fistulous opening is in front of this imaginary transverse line. Whereas the fistulous opening which are falling behind this, line, they are going to have a curved track, right? So this Goodsall's rule actually gives us an idea that what is going to be the track, what is going to be the fistulous route, whether it is going to be straight or it is going to be curved, because whenever we are doing fistulectomy, we have to remove the entire fistulous tract, otherwise the recurrence is unavoidable, right? So this Goodsall's rule actually help us in preoperatively in assessing the route of fistula. If it is anterior to that imaginary line across the anal opening, we can expect a straight route, and if it is behind, we can expect a curved route. This is what Goodsall rule is all about, related to fistula in ano. Right? So now, if you are now, this is, look here, this is 2 o'clock position, right? Somewhere here, this is 2 o'clock position. So again, we can have a straight fistulous track. Right? If it is somewhere around, you can say 6 o'clock position, so or 5 o'clock, then we can presume that it is going to have a curved fistulous tract. So this actually Goodsall's rules help us about the the track of the fistula, because whenever we are removing that track, we have to remove it completely so as to avoid any recurrence. So this Goodsall rule actually help us in preoperative planning. Now, coming to next question, spontaneous esophageal perforation after vomiting or retching is a feature of. Very good, very good. Now here the important word which you need to understand is perforation. The moment you find this particular word, the answer has to be Boiravi syndrome. Right? So perforation of esophagus, don't think of Mallory's, never, never, right? So forceful vomiting or retching is like that spasmodic contraction of the abdominal muscles as if we are trying to vomit out. So perforation, esophageal, Boiravi syndrome. And what is the clinical presentation? Now suppose if this is esophagus and if there is perforation, the entire content is going to leak into the mediastinum, and patient is going to have mediastinitis. So patient will develop chest pain, and also features of pneumomediastinum, that is air in mediastinum. There is pneumomediastinum, and I think must be remembering one month's crunch. So this is Boiravi syndrome, and the presentation is related to mediastinitis. Yes, subcutaneous emphysema can be seen. Chest pain, yes, perfect. So this is Boiravi syndrome. Now, in a repeated question, elderly patient for right hemicolectomy, 4th postoperative day, fever, swelling. This is DVT. If this, yes, Haman sign, Visha, right? No. HIV patient with odynophagia. Now, odynophagia means painful deglutition or swallowing. Right? So there is painful deglutition, and on endoscopy we can see serpiginous ulcers, and more importantly on normal surrounding mucosa in the distal esophagus. So whenever you have this kind of presentation in which there are snake-like ulcers and the surrounding mucosa is normal, especially in a HIV patient, this goes in favor of cytomegalovirus esophagitis. Very good, very good. So this is cytomegalovirus esophagitis. So you can see the ulcer and surrounding normal mucosa. Not too much discuss in this question. Now, next question. There is acute onset abdominal pain relating to the whole of abdomen, and there is abdominal distension, there is tenderness guarding all around, pulse is high, BP is okay. Chest X-ray shows gas under bilateral domes of diaphragm. So I think most of you must be knowing the answer for this. This is of course gut perforation, and better answer amongst C and D will be colonic perforation, right? So because we are getting gas under both diaphragm, right? So bilaterally we have gas under diaphragm, so it means some bigger portion of the gut has perforated, so it has leaked large amount of air, right? So colonic perforation is better than appendicular perforation. Clear? So this is a classical case. The moment you find the word gas under diaphragm, no need to mix up. And here you can see now this white line is actually the right dome of diaphragm. Okay? And then this black shadow is the gas under diaphragm, what you call pneumoperitoneum. Okay? So this, because gas creates a black shadow on X-ray. Okay? So I think no one should err in this particular question. One of the commonest question which is asked. Okay? So colonic perforation. Now, next question. A patient was on broad spectrum antibiotics for a prolonged period of time. Now he is having diarrhea. So what is the clinical condition in consideration? Any idea? Yes, it is antibiotic associated diarrhea, and this is known as pseudomembranous colitis. Pseudomembranous colitis, and the bacteria which is implicated here is Clostridium difficile. Yes, this is antibiotic associated diarrhea, and this is principally seen after antibiotics like cephalosporins or amoxicillin. So this is pseudomembranous colitis related to Clostridium difficile. Now, next question. A young patient has retching, vomiting and retroesternal burn, and appetite is reduced because of the pain during swallowing. What could be the important, or what could be the likely diagnosis over here? Now here one word is quite obvious in making the diagnosis, and this goes more in favor of GERD. Yes, the answer has to be reflux esophagitis because of GERD. So there is retroesternal burning pain. I think this is quite easy to answer. Normally the LES should be tight enough. So the LES should be tight enough to prevent any reflux of acid from the stomach into the lower part of esophagus. So it should not go beyond this point. So this LES. But if this LES doesn't work properly, there is possibility that reflux might occur in the lower part of esophagus, and long standing cases, this is the This is the factor which leads to Barrett's esophagus. Right? So retrosternal burning pain, think of GERD. Now, which of the following is the investigation of choice for GERD? Best investigation GERD. And yes, anyone? What is the best investigation for GERD? Yes, very good. Because the normally there should be no reflux of acid from stomach into esophagus. There should be no reflux. But what happens if there is continued reflux? Now this acidic thing is going to decrease the pH of esophagus. So if we can just monitor the pH of esophagus for 24 hours, yes, everyone is absolutely right. And if we find that pH has really reduced, it is an indicator that yes, that acid is coming from the stomach and it is reducing the pH of the esophagus. So 24 hours pH monitor, best for GERD. Acute onset large volume hematomesis in mild splenomegaly. The answer, I think everyone can clearly say this is a case of esophageal varices, which is secondary to the portal hypertension or cirrhosis in an adult patient and portal vein thrombosis in a child, right till table. Please remember, we have already discussed, and this is how the varices looks like. You can see the dilated tortuous veins, all varices. An old man presenting to the emergency after prolonged vomiting, and there is hematomesis following alcohol ingestion. What could be the diagnosis? Yes. Yes, perfect. So this is Mallory-Weiss syndrome, and here the classical presentation is hematomesis, prolonged vomiting after alcohol ingestion. And in Mallory-Weiss syndrome, you have to remember few terms. Number one, there is partial linear tear, right? Involving which part? Yes, acute gastroesophageal part or cardia end of stomach, right? And also this leads to hematomesis, very important, hematomesis. Okay, so this is Mallory-Weiss syndrome, and if we discuss another points which are Koiravi syndrome, we discuss that there is complete perforation. Right? So here we have complete perforation. This is involving the lower end of esophagus proper, and patient comes to us with signs of mediastinitis. That test. So these are the few points which should be taken under consideration while differentiating the two conditions, Mallory-Weiss and Boyer-Harvey. Okay, so we can proceed further. Now, there is an adult patient who is having occasional dysphagia for solids, regurgitation and foul smelling breath. Now, what can be the diagnosis here? Now here, this is occasional dysphagia. It means sometimes dysphagia is present, sometimes the patient is perfectly fine. There is regurgitation, means whatever he has eaten 2 to 3 days back, it comes to the mouth again and again. And there is foul smelling breath. This is known as halitosis. Whenever you have this kind of, yes, perfect. Whenever you have this kind of presentation, the answer has to be Jenkins diverticulum. And here what happens, whenever the food accumulates within this pouch, right? It can compress upon the esophagus, and this results in actually dysphagia occasional. The food can come back into the mouth, so that is regurgitation, and if the food stays here for long, it will produce bad smell, that is halitosis. So all the 3 points are perfectly explained with this condition, that is Jenker's diverticulum, and yes, this is Killian's dehiscence. Next question. Not a feature of ecclesia cardia. What you will not see in ecclesia cardia? Yes, this is corkscrew esophagus, which is actually entity related to diffuse esophageal spasm. This is diffuse esophageal spasm. Please remember, like we can see bad smell, occasionally regurgitation is there, and dysphagia more for liquids. Now, in early stages of ecclesia cardia, I think everyone knows the pathology of ecclesia cardia. There is dysfunction or increased pressure in lower esophageal sphincter, increased pressure DS, so it fails to relax when the food comes. But the solid food, by virtue of its weight, can dilate LES initially. Patient has no dysphagia for solid food, but liquids can't. So he has dysphagia for more for liquids initially, but later on it is equal for both solid liquids, right? That is one classical presentation in early stages of ecclesia cardia. Yes, solid can pass. Okay, now next question. Elderly patient with gradually increasing dysphagia for 3 months with significant loss of weight. The moment you find this word, significant loss of weight, my dear students, always remember one term, that there can be a possible tumor, right? So this cannot be ignored. This is actually tumor cachexia, and this is gradually increasing. It means there is, suppose if this is esophagus, initially the tumor might be this much size, right? And later on it will increase to this size. So the dysphagia is also going to increase. So gradually increasing dysphagia means the size of the swelling is gradually increasing and it is encroaching with lumen of the esophagus, right? So loss of weight, gradually increasing dysphagia, straightforward you can go to mark your answer as carcinoma esophagus. Yes, Raghu, you are absolutely right. Upper 2/3 you can mark squamous, lower 1/3 most commonly is adenocarcinoma because of the possibility of adenocarcinoma, right? So here you can see in the image, you can see a tumor which is encroaching within the lumen of the esophagus. Now, next question. History of weight loss and dysphagia, and he can take liquid only. He is a smoker. Now, what diagnosis you can think of? Again, you cannot ignore the term weight loss, and here the liquids, they can just slip by the side of the tumorous mass. Very good, Raghu, it's a tumor, yes. So, and smoking can be a predisposing condition here. So the answer has to be carcinoma esophagus. So weight loss, dysphagia, the solid particles they stuck, but liquid they can just make their way through the swelling. Now here what I want to show you in the barium fellow, that if you look at the picture, you can see that this is the normal lumen, right? So you can see the entire lumen has been filled by the contrast dye, but as you come down, you will see that there is a filling defect, right? So you can see that there is a filling defect. Now, normally when we are giving dye, it should fill the entire length of the lumen, right? So it should occupy the entire length of the lumen. But if there is any growth in which is encroaching into the lumen, the dye is not going to fill that area, so there won't be any shadow, and this is known as filling defect. So this is known as filling defect. So if you find this particular term, filling defect, think of a mass which is projecting within the lumen, and yes, of course, the mass can be tumor as well, right? So filling defect, just look at this filling defect like this. The filling defect is some mass. Which of the following is not a risk factor for carcinoma esophagus? Yes, rat tail appearance you can write. Very good. You can write rat tail appearance. Carcinoma, you can remember this word. Okay, not a risk factor for, yes, anyone? No, this is a very tricky question. Like Indians, they are so fond of a spicy food. So spicy food can never be a risk factor for carcinoma esophagus. Mallory-Weiss tear, what is the site of injury? Yes, the answer is gastroesophageal junction, or if there is cardia end of esophagus, whatever is given, you can just mark it. Cardia end of, right. Now, next question, 4 weeks old, non-bilious vomiting, abdominal distension, and because of repetitive vomiting, there is weakness or weight loss. What can be the diagnosis here? Yes, obviously this is hypertrophic pyloric stenosis. In older time it was known as congenital, but nowadays we don't use terminology. It is known as infantile, because you see the presentation is around 4 weeks. A congenital condition should have been presented at the time of birth. It is taking 1 month time. So the better term is infantile hypertrophic pyloric. Yeah, perfect. Non-bilious means the obstruction is before opening of GBD, bile duct. You know that here the obstruction is in pylorus. Clear? So this is IHES. Next question. A patient has a history of upper abdominal pain, was periodic, and it occurs at early morning. Now he is having projectile vomiting, which is non-bilious and contains undigested food particles. Patient appears dehydrated because of repetitive vomiting. So what kind of clinical picture is this? Yes, this is gastric outlet obstruction. So the person was a case of peptic ulcer disease, and now he had gone into a state of gastric outlet obstruction. And since the vomiting is non-bilious, we can say that the obstruction has occurred before the opening of common bile duct. Right? So this is peptic ulcer disease getting into gastric outlet obstruction. And this early morning pain, it means that the pain is coming on empty stomach, and this is quite obvious for which type of ulcer? Duodenal. And this kind of pain is relieved by food. So every time the patient is having gastric pain, he will eat some food. Patient becomes fat, right? Obese, because of too much of eating, just to get that pain relieved. This is duodenal ulcer of. Now, elderly patient with projectile vomiting, weight loss, what abnormality can you expect? Any idea? Anyone? There would be hypokalemia, yes. There would be hypochloremia. There would be metabolic alkalosis, and this is with hypokalemia. So everything will be lost, and there would be metabolic alkalosis, which can be compensated by paradoxical aciduria. So I think it's enough for the day. Thanks to all of you for just continuing with me throughout the day. It was a very exhaustive day, but I am very sure that you must have enjoyed the session and you must have learned something good, and that might help you in the exam as well. So see you tomorrow 10 a.m. Till then, bye-bye.